I do want to thank the key organizers for the event, Dr. Will Ackling and Dr. Carlos Blanco, as well as the incredible team of colleagues that they have behind it. Um, I'm very excited. I just got the numbers of people that have registered, 1,300. I mean, I think that this not just reflects the easiness with which we can join meetings via virtual technology, but the enormous interest in the subject matter. And again, it's rare to have this level of interest for a meeting that was arranged in relatively short period of time. And it does highlight two aspects about it. I think that on the one hand, the recognition that this is something that we cannot justify anymore, the tremendous differences that exist due to racial factors that have grown up actually and exacerbated the health outcomes of individuals. That's one. We can no longer allow, by not being proactive and participating in research that can change it, do that. But I think on the other one, the advances in science and tools that we currently have enable us to tackle it in ways that it was not possible. So we have the scientific opportunity to address one of the most challenging and impactful problems that we face in our society, which reflects the underrepresentation and of, first of all, researchers in the space of science, but also importantly, that has the consequences related to health disparities. We've known all along that socioeconomical factors are driving many of them. And now we have the opportunity to actually to investigate better why is it that they do so? And very importantly, because after knowledge, why do we want knowledge? Yes, we're curious, but on the other aspect to it is the ability that knowledge gives us to come up with solutions to address this. And this is the perfect moment. I have never, I mean, I was not born in the United States, but have been living here the majority of my life. And I have never seen a period like this one when there is a social consciousness that this is something that we need to address. Nor have I ever seen the support of agencies to actually make a difference. And we cannot miss the moment. And on top of this, we have the scientific developments that will allow us and already have started to allow us to investigate how socioeconomic factors negatively influence outcomes in underrepresented groups, particularly for us as they relate to substance use disorder and addictions, and how to take that information to actually target prevention interventions, but importantly, to actually provide the knowledge that can result in policy changes that once and for all will definitively disrupt the structural systems that are perpetuating these differences. So I'm very proud of this moment, and I want us all to embrace it and take advantage of it. And I also look forward to the very interesting 2 days of presentations that also highlight the scientific excellence and excitement between in this area and the extraordinary opportunities. So thanks very much, Will and Carlos, for making this possible. And thanks for all of the presenters to actually participate and attend the meeting. And I look forward to any conclusions or recommendations that arise as a result of the meeting. So thanks very much.
Thank you, Dr. Volkoff, for really setting the stage and kicking off the meeting. I'm Will Ackland, the meeting co-chair, along with my colleague, Dr. Carlos Blanco. Over the next 2 days, we will cover the areas of social determinants of health and harnessing basic science to understand racial disparities and the impact of racism and how they relate to substance use in general and health disparities specifically. So I just want to take a moment or two just to provide context for the overall NIDA effort and today's meeting. So back in June of 2020, the initiative to promote racial equity was formed. We have several work groups under this initiative, including the workplace, workforce, and research gaps and opportunity. And that's why we are all here today. On the next slide, I just wanted to highlight the mission statement of the research gaps and opportunities section. The first is to realize NIDA's commitment to eliminating racial inequities in addiction research, to examine the landscape of health disparities research, and develop short and long-term objectives as well as strategies for enhancing the research portfolio. Specifically, we want to focus on areas where there are known inequities based on race and ethnicity, and focus on research that has the greatest potential to reduce those disparities. NIDA has committed over $100 million over the next 10 years dedicated to funding opportunities. This is an important first step. On the next slide, I just wanted to go over our data collection in our timeline. Since June of 2020, we have been meeting very consistently since then. We've been very aggressive in our timeline in terms of moving forward and realizing these goals. So we were formed again in June of 2020. We've conducted all of these endpoints that you see here: landscape analysis to identify scientific themes, listening sessions and office hours with NIDA staff, requests for information, which we focus primarily on patients, scientists, as well as providers, portfolio analysis to really understand better our portfolio and where some of the gaps lie. And here we are today with the scientific meeting. And all of these data will be important and essential to inform our task going forward in terms of developing a racial equity action plan. On the next slide, I just wanted to highlight and provide everyone with our meeting charge. And the first is to really develop key recommendations for the racial equity plan. Discuss the synergies in health disparities as well as addiction research. As I noted before, we'll focus on social determinants of health as well as basic science research opportunities. And lastly, identify best practices and ways to measure progress. So with that, I want to introduce my colleague, Dr. Carlos Blanco, who will kick us off and introduce our first keynote speaker. Thank you.
Yeah, thanks, Will. No, and I also wanted to echo what Nora and you have said. No, I think this is a very, very special meeting for many of us, because I think for many of us, we have sort of personal experience of discrimination, but also scientific training in health disparities. So in a way, this meeting is the confluence of personal experience, values that have become more important in our society, and also the scientific opportunities that you have highlighted. And also, if we think from the intellectual perspective, I think we can think of sort of three levels. No, one level, which is documenting disparities, and that's very important. The second, that is the next level, would be sort of understanding the mechanism of disparities, and that I think alludes to what Nora was saying about our natural curiosity as scientists. But at the end of the day, the most important is the third level, no, which is once we understand how do we eliminate disparities. And what we want to do really in this meeting is yes, first document the disparities, which are very well known, get a better understanding of the disparities, but get from you key recommendations of what are the best scientific opportunities to eliminate disparities. And I mean, obviously, there's enormous interest in this meeting. No, as Nora pointed out, there's more than 1,300 people that have joined this symposium. We organized this, I think, in like 3 or 4 weeks. So, I mean, people have really opened up their calendars and changed their schedules to be able to. Some of you participate actively as speakers or panelists, and many of you listen to the symposium. So again, very, very excited. We have a fantastic group of scientists who are going to illuminate the discussions. And so I'm very happy to be able to introduce our first keynote speaker, Margarita Alegria. I have known her for about, I think, 20 years, and I really admire her work. I'm very grateful for all the research that you have done and for your advocacy. Maggie is now the chief of the research, disparities research unit at Massachusetts General Hospital, and a professor of psychiatry at Harvard University. So Maggie, whenever you're ready, I'm looking forward to your.
Absolutely. If I could get my slides on. Thank you so much. Thank you so much for inviting me. This is close to my heart, so I'm going to move very quickly in my 10 minutes. Next slide. I think I want to start this presentation by saying we have incredible opportunities. I am thrilled to hear Dr. Volkov because I agree this is the time for really taking advantage of opportunities. I'm going to say that the first opportunity to transform disparities research at NIDA would be to really think, how do we take substance using treatments for the populations where people of color need it, how it best serves them, and how to co-create the services with them. They have to be at the table to actually decide what will work for them. We have to stop thinking that treatments should be in jails, but rather in communities, that they should be given by law enforcement, but actually by mobile clinics, peers, and community health workers that can get very close to our populations. We know right now that only around 30% of people receive any treatment. So it's very, very obvious that what we're offering out there is not the best, because people are associating it with the criminal justice system and with punitive resources. That's not the way to get people to engage in care. Next. I think we've done some work in the population of Medicaid using substance using services. And what we find is that the system is failing them to meet them where they are, with missed opportunities, for example, in making sure that once they're in, they obtain insurance approval for medication and really connecting them to customer services. We also see that we don't have sufficient harm reduction strategies that might help them meet where they are at that moment, and that we need more warm handoffs to integrate both behavioral and physical health with a lot of care management to address their social determinants. Next. We have to change the service paradigm. The service is really where individuals have to find a treatment, where they must prove that the intent that they really want it, where they're not giving a lot of choices of what they need, and where patients are discharged if they don't adhere to the treatment guidelines. Rather, we need the treatment programs to find them where they are, invite them to treatment, and offer them to engage and re-engage either by peers or CHWs, and to encourage them to participate in a range of offerings, and recognizing that relapse is part of the picture. Next. I think the second opportunity that we have is from the change from treating addictions to really focusing on a package of services for reintegration and recovery. We really have to think that the ultimate is not treating the symptom, but actually to make sure that people can reintegrate with dignity into our society. We know that certain groups have a easier chance of doing that related to education and income, but this is where we have to think about what are the alternative resources that we can provide to make sure that people access medication-assisted treatment, but also remove barriers to reintegrate them in the communities where they live. Next. There's an intersection of NIDA's work and complex system. I think we've really have a model that is extremely simplistic, where we need to understand what are the conflict factors that contribute to drug use and addictions. For example, what are the drug environments in communities that are maintained, and why are they maintained? Is it maintained by policies? Is it maintained by the medical establishment? What is keeping those? And then we need to really think about what are models of retaining people in care. What we're finding is the models we're using have very little continuity of care, and we know continuity in treatment is such an important thing. For example, we know that if we pay Medicaid primary care providers more, we could actually reduce the disparities in access to treatments through primary care providers. There's actually great data that's just recently. So increasing the payment to Medicaid providers is a way to move that disparity out. We also know that, drug-related arrests and drug-related incarcerations are overwhelmingly in populations of color. So we need to think, how do we change those institutions so that we can alter that dynamics that put people at greater risk of not recovering? Next. For example, one of the things we see is this might require a lot of organizational culture change. It's not so much focusing on the individuals, but on their institutions that really, and the organizations that really work with them. This might require re-engineering treatment services. It might require investing more in what Medicaid services can offer. For example, we hear a lot from clinicians, administrators, and patients about the lack of well-trained provider networks that can help people recover and reintegrate. We hear a lot about not giving enough information to the population about where they can get services and understand what is covered and what is not covered and where they can get the services that are not covered. And then we need to be able to make sure that Medicaid offers not just treatment for the addictions, but actually that it really helps people do employment coaching, resource navigation, peer supports that help people get back on their feet. Next. The last message I want to say has to do with the need to start with hope to change the substance use and treatment. I have to say that one of the biggest shocks in doing this work for the last 4 years is how much lack of hope there is in the system that it can be changed. This is something that really, really troubles me. People think the system is so resistant to change that although they believe it's needed, it can't be done. So for that purposes, we need to change the explanatory models of why people engage and use drugs. I think it's very important to change the narrative. I think we need to move services outside the clinics. We can't be waiting for people to come because we're not getting the people that need it the most. We need to focus on social needs and modify the success metrics out there. We're not necessarily using the metrics that our own populations want, like quality of life, like lower mortality, better functioning. And then we need to alter the workforce. It might not be that it has to be all with clinicians. It could be peers and community health workers that get trained to offer a warm handoff and making sure that they navigate the trajectory of a very complex system. And then we need to change the payment policies. They have to be centered on recovery and reintegration rather than on just visits, allowing for flexibility of regulations. Next. We know that, for example, everyone complains that there are prescriber shortages, even for getting people into care and giving them medication-assisted treatment, that there's insufficient guidelines for buprenorphine prescribing to get them across the board in many areas, including rural areas. And then that a lot of the policies of prior authorization are causing treatment lags. Policy should be one of the instruments that we really look very carefully. Next. We recently published a paper in Health Affairs for policymakers because we need to influence our policymakers. And we say there are 5 really big things that policymakers should be doing. One is addressing social determinants of health as central to get people to recover. Another one is the flexibility in regulatory policy to make sure that people can access these treatments, to address inequities in access by servicing people where they are, to integrate mental health, addiction, and infectious disease into one public health system, and to accelerate the expansion of both the workforce and the training to make sure that people are ready to roll. Next. I want to end by saying it's really important to focus on institutional policy recommendations. This is where we can focus on what is missing in the neighborhoods to develop social capital for living well and decreasing punitive actions for those that are sick. This is an opportunity to engage with the criminal justice system, with the public housing system, and with the crisis response system to really get people what they need to be able to recover and live with dignity. Thank you so much.
Okay, thanks. Thanks, Maggie. That was a fantastic talk as we expected. We are a little bit ahead of time, so we have time probably for one, even though we will have more time later on during the panel, but we have time for maybe 1 or 2 questions for you, Maggie. So I don't know, Nora, if you have any questions right now, or if any of the panelists have any questions, please feel free to ask the question right now.
Can I ask the question?
Please go ahead, Jalud.
Dr. Alegria, this is really a great talk. One of the issues that I thought might have been a good idea to discuss would be the criminalization of drug use. How would we approach that issue based on what your talk was about?
Yeah, we actually discussed it, and let me say that that paper is in together with Helena Hansen, Matt Turney, Ruth Chin, Richard Frank, and Josh Jafferstein. So it's a group of people. But we actually talked there that we definitely need to decriminalize it by really offering, instead of people going to the criminal justice system, have a different alternative group of options for them. And second, that we need to make sure that rather that the establishment be a punitive action, it be, that people need to then stay within the system of care for a certain amount of time. But for example, even for crisis, we know people with crisis the police tends to be called when we see behavior tied to, for example, the use of substances. Instead of that, if we could engage people, for example, and we give examples in that paper that I said in Health Affairs of how we would engage people with a crisis mobile team that would connect people to services immediately. And then from there, give a warm handoff to the cascade of care that we know makes people recover. So I think part of the problem is how the system is orchestrated now, that if you do something bad, it gets a call, it's really the police that get called, or you enter the criminal justice system, for example, for different actions. And here is where we could actually do a lot more, not only with the court system, but actually with the judges, with what's available. The problem is availability of good services is really not there yet. That's where we should really focus a lot of our attention. How do we move that criminal justice system away from incarceration to more treatment offerings?
Maggie, we had another question. How do you see the work contributing to prevention? I know treatment is an important focus, but do you see the role in prevention as well?
Absolutely. I think, let me say that, there's a lot of great data on the importance of, employment and whether employment is helpful or not. We actually did simulations for mental health and found that it was important. Employment was actually a good in the simulation models for getting people better. However, I would have to say that it's really important not only to offer employment, which I think is quite, definitely a necessary condition, but not a sufficient condition. because I think we need to do this issue of reintegrating people into their communities and into society. Jobs is one, but we need a lot more. We can't depend that giving them employment for a while, it's going to be enough.
So I think we have time for one more question, and I'm going to take advantage of being one of the moderators. So what do you see as, I mean, this could be a whole talk, but what do you see as the main barriers for eliminating disparities right now? I mean, you've laid out a number of initiatives, but obviously the reason things have not been solved is because there are forces pushing back. So what do you see as the main forces pushing back that we should be aware of?
So I think I would say, at least I'm going to talk very rapidly, three. I think one, the service, what we're paying for treatment is insufficient to really cover a very serious chronic condition. We're willing to pay a lot for cancer. We're willing to pay a lot for diabetes, cardiovascular disease. We're not paying sufficiently for treating substance use, one. So I think we need to re-engage and have a stronger package. And I think this administration is willing to put more money into behavioral health. So I think it's the time to go. Two, I think we need to look at what policies are making life impossible for people to reintegrate into society. We have housing policies that actually don't let people reintegrate into housing. We have job policies that don't allow people to reintegrate into employment. And we have actually GED policies that people have had certain substance using problems, they cannot engage. So we need to look at the policies to see where they cut opportunities. And lastly, I really think we need to change regulations, Carlos. I think the regulations we have for Medicaid and for treatment are just archaic, and we need to be able to have some novel interventions and test them if they work or not.
Hey, thanks. Will, do you think we should move? I mean, we're a little bit.
Well, Carlos, I say we go ahead and there's some other questions. Let's go ahead. I have time.
Okay.
Please. I think this lively discussion and very intriguing. So there are a number of questions that we do have in the chat. I don't know if you want to go ahead and go with that, but if there's any other panelists who have any questions for Maggie, please, please go ahead and ask now, and we will moderate the chat. So one question from the chat is, would NIDA support research on structural racism impact on health, and more importantly, interventions to address structural racism? So Maggie, I don't know if your work speaks to that, but NIDA has dedicated at least $1 million to an effort on structural racism specific to substance use disorder and its treatment. So Maggie, your work on how that would impact structural racism in that way.
So I think if I were actually going to invest 1 million, which by the way, I'm going to be very blunt, and I'm blunt, it's insufficient. We've had structural racism for decades, and we need to invest a lot more for that. But let me just go ahead and say, if I was going to invest, it would be on what are the organizational change that we need to do in places that offer substance abuse treatment, so that they reframe what they're doing to recovery and reintegration. How can we reframe that? And what needs to be re-engineered in what the package that we're offering now? The package that we're offering now and the view is that people are sick and they need to recover. But actually, we need to rethink that. People are sick because there's a lot of things in their life that make it really difficult to live today and struggle through what happens. And that means for people of color, I mean, constant problems, in being taken out off the road and checked for things, people having difficulty in employment, scheduling. I mean, there's so many things I could go on and on, but I think we need to change how we think providers work with people, and especially how institutions like the criminal justice system, how the police departments think about their interactions and intersections with people of color. We really need to change that interaction. And we can do it. We definitely can do it.
One question that is in the chat, so I'm going to read for you or paraphrase it, is what, and I think there's been a lot of interest in this, what role do you see for digital technologies in addressing disparities? No, because of course there's the pro of accessing people, but also some downsides of difficulty maybe accessing internet in some geographical areas. No, so.
Yeah. I mean, I'm not going to cover the digital divide because there's so much data on that. I'm going to cover the opportunities that the digital interaction offers. We're doing right now 2 big projects with racial, ethnic, and linguistic minority populations, and everything is virtual. Everything, either by phone or by Zoom. And it's working, I would say, fairly well. I wish we could at least connect one-to-one for people to get that personal connection, because I don't want to say that everything it should be virtual. I think the hybrid model would be best. But given the circumstances of the pandemic, people are taking it on. And it's actually working quite well in people feeling a closeness and also an anonymity in that they can get someone to tell their problems and get a fast response. So I really we're doing all of this work, Carlos, with community health workers, and we would love to also test it with peers, supervised, and I want to emphasize supervised by clinicians, trained clinicians, psychiatrists, psychologists that then provide the backup to make sure that we're doing a good job.
Will, I'm going to continue asking questions until you think we should move to. So I mean, one of the questions that was in the chat is, what do you think are the main social determinants of health? But if I've heard you correctly, I mean, several times you've brought up the issue of policies, and you think that changing policies is one of the things that that is necessary to change that. So I guess my question, maybe slightly inappropriate, but hopefully I still can keep my job at NIDA, is, do we need more research on policies, or do we need to do something else to change policies? Is it the issue of research, or is it a different issue?
No, I think it's an issue of research. Carlos, I really appreciate you bringing that question, because I think we know certain policies had made a big difference. For example, we know the Accountable Care Act, the ACA really changed disparities. I mean, and it changed it in many chronic conditions. I'm sorry, it didn't change it only for, but it did allow for people to diminish that, gap. So we know that is for example, a policy that changed it. I think there are also, like, for example, subsidies that could be given to people that have very poor, for example, very poor insurance coverage, to make sure that they get enough for treating behavioral health care. I think one of the problems we have is that many of the insurance companies give you a very poor package of behavioral health because they don't want to attract you because of adverse selection. So how can we provide subsidies for that to make sure that people feel, no, we really want to make sure. So that's a second one. I also want to talk about for emerging adults, we need to do something about getting them treatment in where people actually, community health colleges. I think we don't have, in the same way we have the school system, the school health system to offer care, we don't have an alternative model for youth in colleges that can offer quick, for community colleges, for example, quick offerings. So I think that, and when we're talking about social determinants, I want to say how important is food, how important is stable housing. I mean, obviously those are, and those are important issues. What we're doing, Carlos and Will, is that we're actually partnering with care managers that at the same time we offer the behavioral health. We also offer you, like, what do you need? Evictions, we'll put you with healthcare legal aid to try to connect you to that service. Do you need some social worker in your children's school? We'll connect you to that. So that is the other component that we need to add to the package.
Carl, I think we.
Let me ask one more question.
Yes, please, one more question.
I feel like I'm doing like an interview, like a or Fox interview. So, I mean, in addition to being a very, very successful researcher, you've been a very successful mentor as well. And I imagine a lot of the people listening to this symposium are junior people. So what advice would you have for junior people who want to focus on these areas? What have, in your experience, made junior researchers successful and eventually become senior researchers?
Well, the first thing I tell my junior researchers is you have to take this with a passion, because the amount of persistence needed, the amount of determination you have to, it's pretty large. But I would say the other thing I would tell my any mentor is collaborate. I don't think the future of NIDA research is going to be solo practitioners. I think we need to have multidisciplinary teams. And actually, Dr. Volkov was in a National Academies of Medicine panel that we did on the environment and mental health. And it was very related to behavioral health, actually. So I think to really focus on disparities, we need to have a multidisciplinary, multi-component interventions. And that will require for us to work with, different people, either sociologists or, epidemiologists or biostatisticians. So I think collaboration is going to be key for people. And finally, I think not letting go to places where they value you as value the work you do. Don't necessarily go to the ivory towers. Just go to places where they're going to value you for whom you are, not independently of what you do.
Great. Thanks so much, Maggie. Thank you, Carlos. I mean, that was just a great presentation and lively discussion. I think you provided some concrete steps forward, and we welcome you to our discussion session later, which I think will be lively as well. We move on to our next keynote presentation, and that is by Dr. Deborah Verholden, who is the director of the Flint Center for Health Equity Solutions. Also, she's the Associate Dean for Public Health Integration at Michigan State University College of Human Medicine. Dr. Deb.
Thanks, Will. And I see we got a little bit extra time, which is why I always have what I call my bonus slides. So if we have more time, I have some bonus slides at the end here but I'll stop at the legitimate end and see if we have any questions. So with my 10 minutes, we got 10 minutes, I'm going to talk about unpacking the causes of the causes and the need to mandate equity to address the social determinants of health. I normally give everybody the 101 so that we're all in the same conversation. But with 10 minutes, I'm not going to be able to do that. So I'm going to give kind of just a quick overview. We use the terms disparities and inequities oftentimes interchangeably, and they're not the same. And I think that's important for us to keep them distinct because they offer different ways of thinking about problems, and then they offer different ways of trying to build and develop solutions to problems. So disparities, literally a synonym, are differences. Disparities are typically the differences that we see, mostly that deals with inequality. This group has more of this, that group has less of that, or this group has more access to this or more access to that. It typically is person-centered or sometimes group-centered. We'll talk about disparities in outcomes. We're seeing all of this play out right now with COVID. In an upstream, downstream paradigm, disparities are typically more downstream, right? And I would even put healthcare and healthcare access in sort of the midstream range, because you got to think, what are the factors upstream that give rise to the need for so much healthcare differentially for groups downstream? And because we talk a lot and we've gained a lot of traction and talked about specifically racial inequity, this is where race would fall. When we talk about race, we're talking about differences between people, downstream things, and inequality. Separate and distinct from talking about inequities. Inequities are unfairness, and literally equitable, a synonym for that would be fair or fairness. So inequities are more about things that are unfair. It deals more with systems and structures as opposed to individuals. They tend to be more upstream. And these are the kinds of factors that relate to things like racism and structural racism and institutional racism, separate and distinct from race. So oftentimes I think the mistake that we've made in the past is we've attributed differences downstream that we see in health to things like race, when in fact, there's nothing special about race that explains variation in substance abuse or addiction. But there are things linked to experiences of racism, whether they be individual experiences or societal, systemic, structural factors that give rise to those differences. So that's what I mean when I talk about disparities versus inequities. And I always say framework matters. And an important distinction that I'd like to make is, sorry, I should have turned my ringer off. I always tell people, think of what's out on the field as everything that you would need for optimal health. And you can see here, there's this fence up. Why? Because these guys got the great view from the side of the game. And in an equality model, we've got resources. This is very much how our world works. We have the resources that we have to get the job done. So in an equality model, everybody gets what their fair share of the pie, if you will. In an equity framework, it's about more fairly allocating those resources so that everybody has the same opportunity for optimal health. I always tell people, I'm not making a value judgment here. I'm not saying one is better than the other. I just want people to have a particular way of thinking about it. The social determinants framework I really like. And again, not one is not better than the other, but they provide different things. Notice here, the fence that was the barrier for people to see the game, which was needed to stop balls from rolling over and hitting the people watching from the sidelines. Instead of a plank fence, it's now a chain link fence. And notice we don't need anything. Everybody has what they need to have opportunities for optimal health or to see the game. And now those 3 boxes, those resources can be deployed another way. And I'll talk a little bit later about, I really think there is a business case to be made for equity that we've just missed the opportunity to really do. So I want to point to something. This is a paper that was published ahead of online, ahead of print back in August, and it actually just hit print yesterday, that was published in Addiction. And the punchline here is African Americans now outpace whites in opioid-involved overdose death. And I truly believe, but for COVID, we would all be celebrating because a tremendous amount of effort was put in and a lot of work was done to turn the tides on the opioid epidemic, which sort of got trumped by the coronavirus pandemic. But the short version is whites have historically had a much higher rate of opioid overdose death than African Americans. And this was a phenomenon that if you go back and you look at national vital statistics data, this has been the case for about the last 20, 25 years. Somewhere around 2012, African Americans started to increase and rapidly accelerate in their rate of opioid overdose death. And what happened in the last 2 years, which followed the declaration from Health and Human Services of an opioid epidemic, is that Blacks are now starting to outpace whites. And I'm almost certain that those lines are actually going to cross. What's strange is that after the declaration of this pandemic and the rollout of substantial resources, a really comprehensive, evidence-informed 5-point strategy, we saw a national decline in opioid overdose death from 2018 to 2019. However, when you bring an equity lens and you disaggregate that data by race, in fact, what we find is that that only held up for whites. It did not hold up for Hispanics and African Americans. In fact, African Americans and Hispanics had a statistically significant increase in opioid overdose death during that same period. And it begs the question, why? And what I say is we actually racialized the opioid epidemic. People were up in arms and really upset that once opioids really hit middle-class white America really hard, it became a problem. That's not the real problem for me. The real problem is the fact that all of these resources were availed. We brought the best science to bear that we had, And then we disproportionately left African Americans and Hispanics out of that. And so this is just sort of an example of, if we don't bring equity to the work and we don't use these very basic and simple tools that we have, we run the risk of things drifting toward inequity. And I'll talk a bit about that now. So my call to action is that we mandate equity. And I don't actually think this was done intentionally. If you look at the data, and if you actually talk to providers, I did a lot of work in the state of Michigan. What we found specifically around opioids is the 3 strongest predictors of, as an example, one of the points in the 5-point strategy, the 3 strongest predictors of who got started on medication-assisted treatment in the ED, which we know is a strong evidence-based practice, was being white, being male, and having private insurance. And when we talked to providers and said, how is that the case? They would say things like, well, we don't want to get people started on treatment if they're not going to be able to continue it. You know, we sometimes don't get people started. We try to make sure we meet some of their other needs and get them health insurance or get them stable housing and some of these other things. So I'm not even implying that it's intentional how this is worked, but in the absence of some real intention to have it be some other way, that's sort of how it will go and what the natural drift would be. So I make the statement that our natural drift is to inequity. I think a federal or even an institutional mandate would push us to figure it out. And we've got great examples of how we've done that locally. And I love how the previous speaker talked about, you know, with Medicaid as an example. If you pay them more, that they'll do things and they'll work harder to ensure equity. Well, one of the things that we've done in Michigan is we've actually attached enhanced Medicaid payments to measures of equity. So if they can't bridge the gap, and as an example, who gets referred for medication-assisted treatment by race, by insurance status, and some of those other things, then their enhanced payments are at risk. We figured out that that was a really great approach because what it did is it forced communities of practice. I'll use a softer word and I'll say it inspired communities of practice, because the places and the providers who were doing well sort of popped their chests out and said, not our problem, we don't have that problem, we're doing great. And the people who weren't really didn't have an incentive to figure it out. So what the mandate does is it sort of inspires or will push people to create communities of practice. And I oftentimes will have researchers say, well, how do I integrate this lens? How do I begin to look at and unpack social determinants of health and integrate that into my treatment research or into my clinical trials research? Again, if there was some mandate for it, imagine if the FOA that you responded to said you have to have some semblance of social determinants of health in your research. It would inspire communities of practice around research. And I do believe we would figure it out. The reason I'm also calling for mandate equity, and it is a hashtag, we're building traction, and that is my social media over there, Dr. Deb Verholden. I say if equity matters, it has to be written, because that's how laws and policies work, right? It can't just be a practice. It has to be written, it has to be enforceable, and it has to be attached to resources. It's gotta be attached to the thing that matters for people. And I love telling the story of when my son wanted a game system in his room. And I said, well, you get straight A's and I'll get you the game system. And I'll even get you a flat screen TV to play the game system on. I didn't get the kid a tutor. I didn't spend more time with him doing homework. I just attached what he wanted to the outcome that I wanted. And he figured it out and got straight A's. I do believe that this fine community of researchers and practitioners would be no different than my son. So if equity matters, it has to be law, it has to be policy, it has to be mandated. I also think there are some key things that NIDA could be doing right now that would improve DEI, diversity, equity, and inclusion across a continuum. We're going to talk more about this in the panel discussion later that'll be moderated by my colleague, Dr. Kathy Etz. So the first thing is you could be mandating equity. What does that look like? The biggest problem we have is called health data disparities. We kick the can down the road for even having the data that would allow us to understand what are the downstream differences that we have and what are the upstream factors, systemic and structural, that might be giving rise to them. So the first thing is we've got to look at the data. Some kind of periodic review of all applications that get submitted by underrepresented minorities and from minority serving institutions. to identify where are the leaks in the pipeline. And I always tell people becoming an NIH funded researcher is hard no matter what race, gender, et cetera, that you are. But we do see time and time again that there's some isms at play. Some of it is disciplinism because URMs may be overrepresented in the social behavioral sciences and NIH might lean more to the bench or the biological sciences. But we've just got to figure it out. And the data exists. So we've got to gather the data and we've got to look at it. And we shouldn't treat any of those variables like discipline or race of the applicant or the type of institution that they're coming from as noise and nuisance and control it out. That actually is the thing that we need to be looking at. We also could create some benchmarks for funding. If we say it matters, historically Black colleges and universities, tribal colleges and universities, Hispanic serving institutions, and American and Pacific Islander, Pacific Islander institutions should also have some benchmark for research grants. Most of the programs that exist right now focus largely on training programs for minority serving institutions, but they don't focus on benchmarks for programs of research and for bridging that leaky pipeline with some of these really great institutions getting in that pipeline for the research grants. Because where are people going to be training people from? They need NIH funded investigators in those institutions. And we know historically that the playing field has not been leveled. We also need explicit funding to integrate equity and studies of structural inequity, whether we be talking about race, gender, gender identity, geography, et cetera, into programs of research, into FOAs, and also into training programs. We need benchmarks for URM scientists. It's sad to continue to watch the percentage, the success rate for underrepresented minorities fall behind some of our majority peers. I think some other DEI opportunities exist around having diversity on council, pipeline programs for URM reviewers. And I don't think you can just have one URM reviewer on a panel. I'll tell you, having been the only one on my panel for more than about 15 years, it's a little intimidating. We also should provide DEI training for all reviewers, and we need to build a business case for equity and community engagement. And because I live in Flint, I'd be remiss to not point to, there's a real business case for equity and preparedness. And I want to end with a couple questions and turn it back over. But the punchline is inequity and racism has a real cost associated with it. As an example, the Flint water crisis cost more than $1 billion of taxpayer money, and that number continues to climb. The Flint water crisis has cost our taxpayers, your federal dollars and our state dollars, more than $1 billion of taxpayer money. What was the cost to upgrade the water treatment system pre-water crisis? It was less than $1 million. What was the cost for an anti-corrosive, which could have largely prevented the corrosion of pipes and leaching of lead? Depending on who you ask, it was somewhere between $81 and $150 a day. So to save $1 million, it's now cost the taxpayers $1 billion. And the real question is, what's the cost to human capital and human potential? We know lead is a real potent neurotoxin, and clearly there's a lot of people who look at lead in the continuum of behavioral health and addiction work. We don't know yet. That's to be determined. And that's the cost that I think really matters the most. We really, with inequity, do compromise human capital and human potential. So the question is, what is the cost of inequity in substance abuse and addiction? And another question is, what's the ROI of equity? So the last thing that I want to say is I think we should make a case for this. And I decided to hold myself to the same standard that I really hope NIH holds all of its investigators to. We did a cost benefit analysis and an ROI examination of my center, the Flint Center for Health Equity Solutions. And we looked at what is the economic impact of the Flint Center for Health Equity Solutions. And we can say with certainty and with rigor, we did the work, we brought the equity focus, we closed the gaps on many disparities in our city, and we did them in a way that's sustainable over time because we engaged the community and they own it and they keep those things stood up. And the punchline here is that an $11 million investment generated $29 million of return. So I hope that once this is published, this is the preprint, it's in its second round of revisions, but I really like this mechanism also because I think it's important that we share in real time the innovation of our work. And I think NIH should have attached as a condition to the funding that they give people a requirement of equity and a requirement of dissemination of findings to support others and scaling that up. Because it's Black History Month, I wanted to end with a quote that I think ties it all together. And it's a quote from Dr. Martin Luther King. And he said, "Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly." I'm gonna stop there and I'll take questions. That's my email, social media, and mobile if anybody would like to follow up.
Dr. Verhoeven, that was fantastic. Thank you very much. There's a lot to take from that talk, and I think the mandate is exactly what's needed in order to move this needle forward in a way that has been long overdue. And so thank you for that. Questions from the panel. I see Jean-Luc. I don't know if you want to kick us off on questions. We have about 4 minutes for questions for Dr. Verhoeven.
Yes, thank you. Well, Dr. Verhoeven, excellent. I've been reading your papers. I was really glad to hear your talk today. That was really brilliant. So my question is, when you're talking about DEI training, do you think that's actually really sufficient with that anti-racism training also? I mean, would you like to discuss that a little bit?
Well, I don't think there's one thing that's going to solve all of these problems for us. But I'll tell you this, having sat on study section for a long time now, I remember when we started the shift to improve the pipeline for early stage and new investigators. And it shifted the culture of how we do the review, because every view, they set the stage and said, and then they set the stage, and then they said, and we're going to review early stage investigators and new investigators first. They would remind us, we have a different criteria for preliminary studies for this group. We have an explicit commitment to increase the pipeline and get new and early stage investigators into the pipeline. I thought that was going to happen once or twice. It happens at every review. We review them separately. It's clarified that this is a priority group. We only triage the bottom 50% on my panel versus with the non-early stage investigators, we triage out the bottom 2/3. So it's like when you make the mandate, right? So we declared COVID a pandemic. A lot of cities across the country have declared racism a public health crisis. When we declared COVID a pandemic, we got societal change, massive resources that got rolled out, standards that got created, protocols that got created. When we did the same thing and we said, NIH said we have a priority for new and early stage investigators, all of these things happen. Racism has been declared a public health crisis in 13 different states and a number of counties that I couldn't even count, and nothing happens. It lives as something that sits on the book somewhere. So that's why I said it has to be written, it has to be enforceable, and it has to be attached to resources. So the DEI training alone won't do it, but if we could get it written and enforceable and figure out what those metrics are, because the other thing is we've got great experts. There are people who spend their entire career in behavioral economics. What's the threshold to get people to do what you want and need them to do? Even on this, in the NIDA sort of world of researchers, we've got people who are very steeped in implicit and explicit bias. So I feel like if we don't take the first step of putting the mandate in place and then figuring out how that mandate gets enforced and carried out and what are the real measurable outcomes and impacts, we'll just get stuck in this world of sort of trying to be perfect and figure it all out, but never make progress. So I don't think the DEI training alone will do it, but it will send a signal to reviewers and others that this is a priority, and likely many other things need to be wrapped around it. And it's really nice to see you, Dr. Cadet. You were one of the first researchers that I met at my very first CPDD meeting where I turned 21. That was 25 years ago, and you were there.
Thank you. Thank you. That was great for you to remember. Thank you.
Yeah, yep.
Any other questions for Dr. Verhoeven? Before we break, we still have time before we break. I think, let's see any. Okay. Well, I'll have one more question, Deb, if you don't mind, before we break. So the mandate, and I think it resonated with me for many reasons, and chief among them are thinking about policy. And I know when you talk about policy changing and how research can really factor into that. And once it really hits the bottom line, the return on investment is what really, you know, it piques many people's interest, especially when you can tie that into dollars. So how do you see that moving forward in a way that can impact policy, but also the bottom line? Because when you think about it, it's all about the economy, right? It's the economy. So how do you really enforce that in a way that can really bring in the research and then impact the bottom line?
Well, and the reason I call it a mandate, I tell people all the time, I have one thing in my life that's unconditional, only one thing, and that's my love. I give my love without condition. Everything else has all kinds of strings attached. My time, my attention, my money, my everything. We've got to stop giving people money with no strings attached. There was a recommendation in the FOA that I applied for that funded my center, that you include a health economist and that you consider some type of economic analysis. That really raised my antenna because I do a lot of community engaged research, and I tell people the power of including community, it's more than goodwill and the right thing to do. And I do think it's goodwill and the right thing to do. We need more science and evidence underneath of it and behind it to demonstrate that it actually yields results. We need to understand the mechanisms by which community engagement and including affected populations, et cetera, actually improves results and outcomes, right? Similarly, we need to understand what is the impact of inequity, what's the impact of equity, and what is the return on all of these investments. I go to the NIH reporter database, and I do it before every sort of talk where I know there are going to be a lot of NIH funded investigators present. And I just go in the keyword search and I look for the word trial. And it never fails. I've been doing it for about 5 years. I have a slide that's in my bonus slide that actually has the number as of today. You will find a quarter of the number of applications that are funded in the reporter database with the word implementation in them. We love the RCT is like the shiny nickel of the NIH research world. But at what point do we take the things that we know work and scale them up and out into community and really do the work of figuring out how to do that fairly, equitably, without losing the impact of these, you know, really great, rigorous RCTs that we've done. And so I think that the way you have to do it is it has to be built into the funding. And again, people will figure it out. They'll figure it out. My health economist had never done an analysis like this before. And now he's an expert. And we've got 5 other centers begging us to do it for them.
Well said. Well said. I think that's, we're going to end on that note. And we will now break. We have about 6-minute break. And then we'll get started promptly at 10 after. Thanks a lot. All right, welcome back, everyone. It is now 10 after the hour. We are going to move into the discussion session, priorities for racial inequity.
Hi, can everyone hear me? Great.
Yep.
Did we lose Will? I hope we didn't lose Will. Well, hello, everyone. I'm just going to jump on in and get started. I'm hoping that Will is going to be able to rejoin us if we've lost him. I'm Aria.
Yeah, I think there's been some problems with connectivity in some of the panelists. So go ahead, Aria.
Yep. Okay, great. I'm Aria Crump. I'm the Deputy Branch Chief for the Prevention Research Branch at NIDA. And I'm very pleased to moderate this discussion session today on priorities for racial inequality research related to substance use and addiction. We were very fortunate earlier today to hear from Maggie Alegria, and she's going to be joining 3 additional distinguished guests for this discussion period: Dr. Sandra Galea, Dr. Helena Hansen, and Dr. Wisdom Powell, excuse me. So just very briefly, Dr. Sandro Galea is a physician, epidemiologist, and author. He's also the Dean and Robert Knox Professor of Medicine and Psychiatry at at Boston University School of Public Health. He's published extensively on peer-reviewed literature and is a regular contributor to a range of public media about social causes of health, mental health, and the consequences of trauma. Dr. Helena Hansen is the Associate Director of the Center for Social Medicine and Humanities and a professor of the Departments of Anthropology and Psychiatry at UCLA. She has published on social determinants of health and institutional racism, among other topics. And Dr. Wisdom Powell is the Director of the Health Disparities Institute and an Associate Professor of Psychiatry at UConn Health. Her community-based research focuses on the role of modern racism and gender norms on African-American male health outcomes and healthcare inequalities. I want to encourage everyone to take a look at the bios of our speakers, as these very brief introductions don't begin to reflect their extensive accomplishments. So right now I have 2:12, and we have about until 3:10 for this discussion session. I'm going to ask our panelists to weigh in on questions that were selected by the Planning Committee. And at the end of the session, I'll close by giving each panelist an opportunity for some final remarks. So if we're ready to begin, everyone. Great. So I'm going to tag Maggie Alegria first and ask, first off, we really enjoyed your presentation this morning. So much power, so much information. But wanted you to speak to how you think we can more effectively study the interactions between race and social, psychological, and structural factors as they relate to substance use and addiction.
Yeah, one idea that I have, because I want to hear also from the other panelists, is the importance of NIDA to be able to construct a data set that actually captures a realm of factors that is offered using the model that was done for the collaborative psychiatric epidemiologic studies that can combine data at the level of the individual, but merging data with, for example, CDC prescription data with SAMHSA block grants, with Medicaid enrollment and use of services, with zip code, with health resource and service administration data, with federally qualified, we need data sources that are merged, that allow us to do more elaborate simulations and actually more allow and see the interactions that are more from the systems affecting the individual. I think right now American Community Services, if we were able to join something like the data warehouse that was done in Massachusetts, that actually combines a lot of data, so you can really look at this in a more interactive way than the way that we're really trying to do with pieces and joining the information. I think we would do a much better job, and it would be available for a lot more researchers that don't have the infrastructure to do this complicated disparities work. I'm going to stop there because I'm sure the others have great ideas.
Yeah, would anybody like to reflect further on data or provide another perspective? Feel free to go ahead and speak up.
So perhaps I could provide another perspective. So I just want to begin by saying I'm an addiction psychiatrist, but I'm also an anthropologist. And my comments draw on a guiding principle of social science of medicine and of critical studies of race and gender. And that's that of the master narrative. That means the story or logic around which a society or institution organizes itself. So it involves selective perception of reality to confirm that reality, and this leads to self-fulfilling predictions and received wisdom that's resistant to change. So in academic medicine, the master narratives include excellence through individual competition, better living through new technologies for individual consumption. They imply that health outcomes are driven by individual risk factors and behaviors, and that scientific disciplines that focus on the individual can explain racial inequalities in health. They imply that Black biomedical scientists, who currently receive between 1% and 2% of NIH R01 grants as PIs, that is the case because there's a shortage of qualified and motivated individual Black scientists. And when pipeline programs based on that assumption fail to increase the number of Black people that actually train people in medical science, when those programs fail to raise the percentage of Black NIH-funded PIs, the unspoken master narrative is that Black people are deficient in the qualities that make excellent scientists. And this enables the continuation of a system in which, consciously or not, largely white scientists trained in a select number of individually focused disciplines that dominate NIH portfolios continue to positively review and promote from their own ranks. And this allows them to ignore the evidence that Black scientists, especially those who propose to study inequalities, not only are less likely to receive R01 grants than white scientists who have similar levels of training and publications, but those Black scientists who do receive R01s have higher average review scores than their white counterparts who receive R01s. That means that their white counterparts are actually assisted by review sections and directors in getting grant awards, even if their proposals are not scored at the top. And this allows them to overlook the finding of one study that Black scientists report being pushed off of the research track by those grant review experiences and by a quote unquote chilly environment among their colleagues in their universities. So I just want to put that on the table, number one, as a master narrative of the scientific enterprise to be examined. With regard to addiction and substance use disorders, one of the master narratives that susceptible individuals have deficient biologies and or negative learned behaviors, and that on the population level, some racialized others are deficient due to their cultures of poverty or inherited traits. Another master narrative that's pervaded American medicine itself for a long time is that Black patients are less sensitive to pain and more likely to misuse pain medications than their white counterparts. So master narratives like these have shaped our realities, as we see in mass incarceration of Black and Latinx people driven by racially motivated drug laws, as well as the opioid crisis beginning in the late 90s to 2000, that began with racially targeted drug marketing, relaxed regulation, and opioid prescribing to white Americans thought to be less susceptible to addiction. So this is a moment in history that we have an opportunity to change the master narrative. The past year of undeniable racial inequalities in COVID prevention, treatment, and outcomes in our country, and publicly televised racial violence by police, among others, have led academic medical centers and leading medical journals to call for self-examination around structural racism, an alternative master narrative. The idea that our institutions, from clinics and hospitals to medical research infrastructures, education, and law enforcement are the source of racial inequalities is new to many who work in those institutions. The idea that social determinants of health should be a top priority for creating knowledge that actually improves health outcomes is also new for medical researchers who have long used explanatory models of molecular process and individual risk. So I'm just going to end now by saying, what does taking this new structural narrative seriously call on NIDA and health researchers to do? And I want to suggest, number one, bring non-NIH supported researchers to the table for scientific planning and for study reviews, particularly those personally affected by structural inequalities and social scientists who take social networks, systems, and institutions as their units for study of inequalities. Otherwise, the NIH and other gatekeepers in medical research will reproduce the status quo as they prioritize and review based on existing scientific approaches and professional networks. And we've seen this over the decades, pipeline program after pipeline program. They have not produced results because they are not focused on the structures. invest significantly more public research monies in social and systemic level research, guided by people with critical perspectives based on their lived experience and or based on their training, their scientific training in fields that have methods and theories to study those systems. Sociology, anthropology, political science, economics, among others. Those are seriously underfunded when it comes to NIH research proposals or portfolios. And then third, learn from the organizations that have produced 70% of the Black doctors in this country and 50% of the Black scientists in this country, that is historically Black colleges and universities. They use a different master narrative of science, not excellence through individual competition, but rather excellence through responsibility to community, which fosters collaboration and mutual aid. As studies of women and people of color in science have shown, they succeed by doing science differently and have insights that show the blind spots of mainstream science that prevent us from creating knowledge that actually improves the health of all. So that's my statement. Thank you.
Great, thank you so much, Helena, appreciate it. Before we jump forward, that was a mouthful. Would anybody like to respond? Anyone on the panel like to respond to what Helena just said?
Let me, first of all, Dr. Crump, thank you for having me. And it's really a privilege to be here with Professors Hansen, Alegria, and Powell. I sort of agree with both Professors Hansen and Alegria, and I actually think that there is a place that synthesizes both these points. And I was listening to Dr. Verholden's talk earlier, and what I was struck by in Professor Verholden's talk is, and I think echoed well by Professor Hansen, is that what we are articulating is a fairly radical vision, right? It's a fairly radical vision of a rethink of the, as Professor Hansen called, the dominant narrative of science, which I really like. I often use the term sort of how we talk about the things that we do, how we talk about health. And to achieve that will require many, many steps. And I think sometimes we mix up in our conversations the radical nature of the vision with the need for every step being radical. And I would argue that in the context of this panel, where we're talking about how does a responsible, responsive, thoughtful National Institutes of Health, in the specific case NIDA, but really any institute, how does it move towards that vision? And I suppose I would like to suggest that we need to have clarity about the radical vision and embrace the fact that there are actually many small incremental steps that all of which together will contribute towards getting to that radical vision. So let me just use one concrete example, which Professor Hansen's comment and actually reflecting on Professor Verholden's comment earlier reminded me of. One of the things that I have encountered for 20 years on study sections, and I've always tried to fight it with limited success, is the sentence that goes something like this, which is, somebody raises a critique and somebody else says, yes, but I know her and it's okay. I know she can deal with that. And which of course, that simple statement embeds right there everything that Professor Hansen has talked about, which is it embeds the sort of in-group biases and sort of entrenches them into part of the process. And whenever I face that, I've always tried in study sections to say, well, the charge is to evaluate what's written, and the fact that we may know that investigator is actually beside the point. So when we say that because I know her, I know she'll be able to deal with that, that is simply saying, well, the converse is, well, because I don't know the other person, then I don't know if they'll be able to deal with it. So I'm bringing that up as actually a micro example. I'm actually bringing it up as a really, really small example. And I think something like that, and please don't misunderstand me, I'm not saying that's a solution to anything. I'm just saying it's simply one small drop in an ocean of solutions that we need to achieve a radical vision. So I'm trying to push us to think, what's the radical vision we're trying to achieve? And I actually think that Professor Hansen said it beautifully, like we're trying to actually achieve a different conception of how we do science. Science that's much more responsive to fundamentally what we're trying to do, which is improve the health of populations, recognizing that the way we've done things has served us well in some respects, not in others, that we need a new vision of doing that. But to achieve that vision is going to require many, 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 many steps, some of which are not particularly glamorous, some of which don't seem particularly radical, and slowly they will accumulate to actually creating the radical vision we're trying to achieve. And I feel like we're at this moment where we're having these conversations, and experience teaches that none of this change is going to happen quickly. And I suppose I don't want us to get discouraged. I would like us to keep the radical vision clear in our mind and have a commitment to making all the incremental steps needed to help us get there. That's just by way of framing.
So I really
Okay, please go ahead. Dr.
Yeah, I'm going to try to be brief here because I know we need to move to the additional questions, but I really appreciate the perspectives that were just laid out by my colleagues and all of the rich dialogue we've been having this morning. And when Sandra was just talking about the radical vision, it reminds me that, you know, the work that I have been undertaking for the past 20 years has really all been about achieving a vision for radical healing. And I've been talking about this explicitly in the context of recovering from epistemic violence, which is where we are now. And I think that when we talk about radical healing in the behavioral health equity space, we're talking about the design of multi-systemic approaches that focus on root causes, collective strategies, and the legacies of resilience in Black, Indigenous, and communities of color. I think that what Helena has laid out is so critically important, and we often skip over this piece. But Chimamanda Ngozi Adichie also warned us about the dangers of these single stories that actually contribute to the types of resource allocation and decisions that we make, both at the grass tops and grassroots. And what that looks like in the space that I occupy for an agenda that focuses on the health and well-being of boys and men of color in our nation, what that agenda looks like is rewriting the master narrative that teaches us to perceive boys and men of color as problems to be solved rather than as wonders to behold. And I am principally sure that a large part of our inadequacy at addressing health inequities for particular populations is because of the deep, abiding empathy gaps that we experience for these populations. You cannot solve or design solutions for communities that you don't fundamentally love. And I do mean that. I mean that we have lost sight of the humanity of populations that we have othered. And because of that, it contributes to linearity of methodologies that don't rise up to meet people at their highest intentions for radical healing. It results in us treating people as if they embody pathology, as opposed to creating therapeutic landscapes where people can heal, grow, and thrive. And so when I think about the state of the science or behavioral health equity for boys and men of color, I think about the fact that most of our lenses on this work have not been intersectional. And so we have created a body of science that results in horizontal equity, where we create a strategy for resolving the unequal treatment of women and girls when we talk about gender, but we forget that men and boys also have the highest rates of behavioral health disparities, particularly mortality-related disparities in our nation. And that the data suggests that men are withdrawing from the labor force because they are taking opioids daily or other substances daily. That the fact that we're hemorrhaging this talent and the potential for these men and boys to contribute to our economic vitality suggests that we have a blind spot. And that blind spot isn't just methodological. That blind spot is actually resulted from our inability to fully embrace folks in our society that we've cast away, that we've buried alive. And so I think that the methods that we deploy in this time have to acknowledge the institute arrangements of individual lives. And we've talked about this. So the scholarship focused on the social ecology of behavioral health disparities or inequities are principal to moving the needle, and also principal to changing that master narrative that suggests that people are hardwired for disparity and inequity, when we know that it is the opportunity structures that give rise to the decisions that individuals make. Living in a food swamp, a food desert, has considerable implications for the health behavioral decisions that a person makes. It is not just that people are using substances because they are without moral character or without uprightness. And I think that that sounds simple, but we are still legislating and designing policies that frame individual behavioral choices as the primary catalyst for behavioral health disparities. And we know that that's not the case. So when I look at the horizon, I think that we need more support for methodologies that reach individuals where they live, work, play, get educated, get healthcare, et cetera. For the past 20 years, before it even became sexy, I was in barbershops, I was in nightclubs, in car washes, in street corners, intercepting young men in the places where they live, because I understood principally that these men who were not going to show up in our health systems were being left out, edged out of opportunities to improve their behavioral health. And I think that if we're going to design a new agenda, a radical vision, then it has to address the identity-based wounds that individuals face when they're navigating systems and structures, because it's those wounds that give rise to the behavioral health outcomes that we see, I think, most principally and most proximally.
May I just clarify something?
Yes, please.
Because when I said I had an alternative view, I actually wasn't referring to Dr. Alegria or Dr. Galea or Dr. Powell, who are my mentors, colleagues, co-authors. I was referring actually to the standard narrative that is given about where health inequalities come from, where the inequalities in NIH funding and who is a PI on NIH grants comes, where those inequalities come from. So I want to clarify that, because I actually don't, this is very productive in that there are some nuanced differences in our entry points for this conversation, but I think we're actually saying the same thing. And we need big and small interventions to get to this alternative vision. So I just want to make that absolutely clear.
Can I
that
add
I am
something?
in full agreement with my co-panelists.
Can I add something to Professor Hansen and Powell's last comment? And the word which I've found myself writing more and more about in the past few years, really building on sort of a couple of decades of sort of building on this, is the need for compassion as part of this radical vision. And I've actually written on this, and I do want to distinguish compassion from empathy. And empathy, and I've sort of written on this for people who are interested, empathy means I want what's good for you because I can imagine how hard it is for you, right? Compassion doesn't mean that at all. Compassion means that we actually want what's good for communities and populations because it's the right thing to do, which means even if I cannot understand what you're going through, it's still right that we actually are promoting your health, your well-being, making sure that we create the conditions for you to have a full, richly realized life. And I feel like one cannot really think about population health. I'm using the term generally, we can talk about community health, but let me use the term population health for a second. Without a radical vision of compassion, that our goal as scientists, and if I may just use the term sort of generally for this discussion, is to create scholarship of consequence that aims to improve the health of all populations so that all humans have the capacity to live rich, fully realized lives. And I don't think that we can achieve that without a radical compassion as part of that vision. And everything else that we're talking about then, I sort of feel like if we can have the radical vision, everything else we're talking about then falls in the service of that. And then I feel like we can have arguments about, well, maybe this is more effective than that. And I refer to Professor Hansen mentioned sort of systems thinking and thinking of the complexity of these forces, which I couldn't agree more. And I think that's a really interesting intellectual discussion. But fundamentally, it's in the service of a radical, compassionate vision that says that all of us in the health enterprise, our role should be to do everything we can to create health as a means for everybody in our society. Now we're talking nationally, but we talk globally as well, to live full, richly realized lives. And just one last reflection on Professor Powell. Health inequities are avoidable. They are the result of decisions that we make in our society. And often in my talks, I make the point that we choose to have health inequities. And when I say that, it sort of upsets people. And people say, well, I don't choose that. To which the answer is, well, we do. We actually do, by virtue of the fact that we choose and accept particular approaches, scientific approaches, policy approaches, we are choosing a particular conception of the world. So I suppose the radical vision I'm suggesting is a radically compassionate vision that says our role is to make sure everybody, regardless of their identity, whatever axis of identity it is, has the opportunity to live fully, richly realized lives. Everything else should be in the service of that.
And given that, how would you or the other panelists see NIH's research enterprise as being most responsive to those particular needs? How do we make sure that our research informs racial equity?
I just want to highlight one of the last points that I made, which is that we need to bring people from outside of this very tight circle at NIH. And I'm aware that many on this call are among the handful of extremely successful NIH-supported researchers that do take seriously this radical alternative framework or narrative that we've been talking about. But there are very few actually by systemic design. And in order to break that cycle, we're going to have to bring in people who are extremely successful scientists and researchers outside of the NIH framework. And that can be it can be hard for those who are very embedded in NIH to believe that there are such people, but actually there's a whole universe of such people who are supported in other ways by foundation grants, by their institutions, and many other ways, particularly because they do research differently. They take on different questions that are the questions that we're saying are priority questions, using different methods, different approaches. The ones that we're saying now need to be fully invested by the public monies with which NIH is entrusted. So we cannot break this cycle with the existing group. We're going to have to reach outside and pay a lot of attention to those scientists who bring lived experience of these inequalities to the table, which gives them an inherent embodied critical perspective and helps them to see things that other predominantly white scientists have blind spots around. Many of them do. We also have to take seriously those trained in disciplines that are not prioritized by the NIH right now. Those tend to be the social sciences. That's not where the majority of NIH funding, and NIDA funding in particular, is going. So I just want to emphasize that point, that we will have to make some big changes in that regard with regard to leadership and direction.
We heard a couple of comments earlier, one referring to the situation with NIH and RCTs, another one about, should we be prioritizing policy research? Are there any thoughts about what our research that will help us move the needle toward influencing the change, whether it's a paradigm change in terms of how we see these problems, right? Or whether it's a change in terms of how we review our research. Are there particular recommendations that you would have there?
So my head is really full right now because I'm thinking of all of the ways in which we engineer inequity and by design into the review process and into what we value. My mother always said, what you value shows up in where you spend your money. And if you invest your money in brain addiction only research, if your portfolio is heavily weighted towards that, that's saying something about what you value in terms of an explanatory model for why these behavioral health inequities exist. And I also, as someone who works in an institute that has a legislative mandate, my day-to-day work is about translating what I learn through my scientific research into action. So creating evidence for action. I think that has to be a part of the charge of the NIH writ large if we're really going to reduce the lag time in between scientific discovery and novel implementation on the ground. I mean, part of the biggest frustration for me as a scholar activist in this space is that we have so much time in between when we finish a study or learn something new to when we actually share it to the community, so much so that the needle has moved on the catalyst or even the wicked problem that we're trying to resolve. So the catalyst or the problem has moved, and also the nature, the shape of that problem has changed by the time we show up. And that just cannot be. We are hemorrhaging intellectual contributions in this space because of that lag time. So how do we then move beyond just incremental science as usual? How do we incentivize more moonshot approaches to this work? How do we bring other sectors to the table? If I'm talking about creating therapeutic landscapes where boys and men of color can heal, grow, and thrive, I cannot do that without an urban planner at the table. I can't do that without someone at the table who understands transportation systems and the intricacies of housing policy and education. So I think that we talk a good game in this space about wanting to have multidisciplinary and even transdisciplinary science. But when we look at what we fund, it's incremental and it's moving the needle along. And it's because we had that policy, I think, science gap. And I know that there are, sort of rules around how we do this within federal government, but I just feel so strongly about not only just for the sake of moving the science forward, but for engaging communities, because they're tired of us talking and not walking and not moving the needle. They're watching, NIH invest hundreds of millions of dollars in scientific discovery and nothing's changing. They're still seeing, distressed economic conditions in their communities and drug dens and other spots that incite cravings for people who are substance dependent. So how do we even explain to the folks that we're working in the service of what we're doing? And I think that we have to hold ourselves to a higher standard, a speedier standard for translation of our evidence into action.
Yeah, that's very well said. Thank you so much.
I think you have heard, from so many people, the importance of bringing a group of researchers of color to actually look at NIDA, what it's reproducing in its funding, in its training, in its, even supplements, how it might be excluding people in a certain way. This is the same as the ventilators, don't give them to people with chronic conditions, and that takes away a lot of people of color. So we are doing, we basically have decision rules that we should examine across the board for NIDA to see is in any way are we excluding a different type of research that is needed in that second narrative.
So Margarita, I'm so happy that you mentioned that, because it actually resonates with me as someone who's a men's health researcher. So I'm going to do a little soapbox and then move on, because I want to be respectful of my colleagues. But so most of the research calls for research on sex and gender research explicitly exclude men and boys, as if men and boys are not gendered and don't live within gendered social-structural arrangements. And it's as if male gender and power are equitably distributed across men from all sectors of our society. And that's that horizontal equity I talked about before. It's like you focus on women and girls. I'm a woman who was once a girl, very happy to have a programmatic approach to women's health. But what is keeping us from being able to see the disparities that lurk in the intersections for men and boys? It's because of the way structurally we write our RFAs and our PARs to exclude, a population who, even if they have male gendered privilege in some areas, it doesn't translate into a health advantage. So why haven't we shifted the way nuanced ways that we're talking about intersectionality? I'm going to keep saying that because I think any equity agenda that isn't intersectional is missing, folks. We're seeing it in the vaccine rollout, how we, chose older Americans, but didn't consider that if you look at life expectancy differences across racial and ethnic groups, the folks who are in that older Americans category may overwhelmingly be white just because of the design, the demographics of our society. So again, I think we have to get more nuanced and much more conscientious about even how we're writing up announcements for proposals and considering who's not at the table, proverbial, metaphoric, or otherwise, like that should be with respect to this particular outcome that we are trying to impact.
Great. I'd like to just interject.
I couldn't agree more with what Wisdom Dr. Powell so eloquently just said. And I want to get back to another point she made previously, which was about the research to practice and policy gap, research to action gap. Another unspoken element of the dominant scientific master narrative is the idea that scientific rigor comes from some sort of distance between the researcher and the subject, that dispassionate, unattached research is more rigorous in some way. And I think what Dr. Powell is raising is actually a very alternative scientific narrative around invested and committed and interested scholarship. And what it speaks to is the blind spots that come when the researcher is distanced from the subject. You know, she gave really wonderful examples of those blind spots. And there's a different epistemological model of rigor that comes from the filling in of those blind spots through researchers who are bringing lived experience and multiple perspectives to the table. There's actually a formal theory of it in science and technology studies called standpoint theory. The argument that scientific rigor comes from bringing in people from multiple standpoints that can identify those blind spots and increase the rigor. But what that also opens up the possibility for is a very committed and active and engaged scholarship and research that is very quick to bring insights from research to action on the community level in policy making. And that's a different model, and it requires a different infrastructure. And I think that's another piece of the new narrative that we need to seize the moment to engage right now and promote. Otherwise, how does our science actually improve the lives of people that we're studying? And then what is the point of the science and the knowledge generation?
Right, absolutely. You know, we've talked a bit about how different areas of science may not be represented as well. One question I wanted to pose to everyone is, are there particular areas of research, for example, stigma research, or really, you know, understanding disparities around treatment access and treatment availability? You know, what are the types of the areas of research that you all see NIDA making an investment in order to do a better job of addressing equity issues?
So I'll just pick up on a thread that I think Margarita laid out in her beautiful talk earlier, when she was talking about the capacity for us to merge data. So big data approaches are so important when you think about being able to determine which of the social experiences are catalyzing people's behavioral health decision-making. I think you need to have some capacity to wed administrative data to primary data that's collected, to data that can be drawn down from some GIS systems, so that we can really look at the landscapes in which individuals live in for opportunities for igniting interventions. And I also think, you know, this is my pet peeve around research that focuses on Black, Indigenous, and people of color, is that we rarely, and I'm not saying not at all, but rarely do we apply or invest in work that gives us a life course developmental understanding of how people come to use substances over the period of one's, you know, lifespan. We know, for example, that Black adolescents start out, you know, using substances at lower rates. And then something happens as they enter emerging adulthood, that time when ecologic exposures are more pronounced and also confronted more autonomously. So what is it about that developmental period? What can we learn from studying those critical developmental transitions about opportunities for prevention or mitigation? I also think that we need more, you know, real time, and I have to credit Dr. Deborah Holden for leading me down this path many, many years ago, to sort of thinking about the use of technology as a way to reach people where they are. So how do we, not only do we leverage technology to explore the ecologic unfolding of substance use, misuse, and addiction, but then how do we also carefully monitor our approaches so that we're not recreating inequities through the use of AI that targets and stigmatizes those we're studying? So it's like a two-way street here with respect to technology investment. One, investing in more technology for the research, but in also studying the implications of using those technology in communities where access to resources are more lessened by the social conditions. So I think all of that is essential to being able to create a more nuanced agenda. But none of that will be possible if, in fact, the lenses, the mental models we use frame communities that are more at risk for these kinds of exposures as pathologically and biologically determined beings. You know, if we don't move away from that strict reliance on biobehavioral explanations, then we will miss an opportunity to change the social conditions, which I do think are changeable.
Let me just add to that for a second, what Professor Powell just said. I think it's inarguable that in art and literature, in the humanities, if you just bear with me for a second, that substance use and substance misuse is a product of the life course. It's a product of the full range of social conditions that characterize inheritance over generations, the assets and the stressors and the life experiences that then create people who then may use substances, who then may have substance use disorders. Like in literature, this is sort of commonplace. Like there's an abundance of literature that does this. Now, there's much less science that does this. So the question is, why is that, right? And I think the answer, just being very pragmatic, is it's sort of harder to do, right? It's harder to do. I think, Professor Alegria started off by saying, we need data that allows us to do that. And I don't want to lose that point because I actually agree completely with Maggie's point on that. So I suppose there are two ways we can go about with that, right? Number one is to say, well, we sort of know that this is probably important scientifically, but our structures for how we do our science sort of limit us because it's just harder to do. It requires a different way of doing it. So therefore, let's just keep doing what we're doing. The other approach is to take Professor Hansen's point to say, well, actually, we need different dominant narratives, different models. And if we accept that it is important to understand the intergenerational transmission of social conditions and the full set of life experiences that then become substance use disorders, and if our systems do not lend themselves to scientific inquiry around that, then maybe we should pause and say, maybe we need to change our systems to allow that to happen. Now, the bad news is that's hard to do, right? The bad news is it's actually hard to do because we have systems, we have large systems. NIH is the sort of world's largest funder of research. I was going to use the word biomedical research. That's probably accurate, but it's probably not generous. But other funders in other countries have actually done innovative things that we can learn from. I mean, I have the privilege of reviewing grants regularly for the UK KPRP, I never remember their acronym, but essentially is the equivalent of what NIH is. And they have developed some really interesting funding mechanisms, which every time I review for them, I'm thinking, oh, this is interesting. We don't have an equivalent here. I'm not saying that that's what we should do. I'm simply saying that if we start off by saying, what should we be studying? What should we be doing? And if our goal is to understand the complexity of forces that ultimately drive and create health, well-being in the absence of health and well-being. And if our systems do not let us study it in the way we should to the end of improving population health, then maybe we need to step back and say what from our systems needs changing. And I feel like we don't do that enough. And I actually, I'm trying to give us all the sort of the generosity of the doubt that we all mean to do this right, but we keep falling short because it's just really hard to do. And maybe at this moment in time, in the spirit of hope emerging from this very difficult year that we've all been through, it's that we are now seeing this very clearly. And now is the time to say, okay, which aspects of our systems do we need to inflect to get at this new model, this new dominant way of thinking?
But Sandra, I think it's a merging of both. I think we need both the systems to study, the systems, but I also think we need data that's at a bigger level that gets collated so that, my biggest worry is it's also creating who can do the research and who cannot, because some of these studies are so, they're so ambitious that you really need like a very heavy set, and it's really limiting who can do the research. And I think that, to me, there's three areas. The doing a new narrative of new models with really rethinking, you know, in a broader sense. I think getting good data to actually test other models. And lastly, I think NIDA needs to look at themselves as the unit of analysis in how it does research, it might be perpetuating certain disparities. So I think it's the three things at the same time.
May I just add a data point, a fun, perhaps interesting data point that reflects what Professor Alegria just said, and something that Helena, Professor Hansen said a while ago about sort of who does the research. One interesting exercise is look at the list of the most cited social scientists, which used to come by Thomson Reuters, now is by Clarivate. And the reason I'm actually suggesting that is when you go through that list, you find that the majority, if not the vast majority of people on that list, are people who have been part of large ongoing studies. So actually, when you look at the most cited social scientists, the way to become a most cited social scientist is to be part of large ongoing studies that have sort of over generations of scholars generated sort of papers and papers and papers that are cited. And I'm not necessarily arguing against that as much as I'm arguing that that is just a simple illustration of how difficult it is for new ideas to emerge. Because of course, being most cited then opens doors and creates opportunities for more work and all that. So I think this theme is emerging super clearly about the need to make sure that that these alternative perspectives that now we're discussing become embedded in what we do, and we don't lose them when this moment is over.
Yeah, thank you so much for that. I want to jump onto this question that we have around, we have research that's shown that some PIs of color are underrepresented in NIH funding, and that a part of what is happening is that there's a difference in the types of topics that they propose in applications. And so one of the questions that we wanted to pose to the panel is, whether there are topics that we really should be looking at that we're not paying enough attention to that might affect our ability to support more PIs of color.
Hi. So I wonder if I could lead in by just going back to a question you posed about stigma, because it might illustrate some of the points. So I think that what we're seeing now is an uptake in interest in stigma among clinical researchers of substance use disorder in particular, because they've run across it in so many of their studies. And they will often cite Irving Goffman, a sociologist, who decades ago teased out the systemic nature of stigma and its creation and reinforcement. But in the hands of clinical researchers that don't have a robust concept of social systems, the idea of stigma has been individualized. So it's how do people rate their personal experience of stigma, how they behave in relation to that. And it leads to some inaccurate assumptions. So for example, the idea that redefining substance use disorder as a biological problem, as a medical problem, will in itself solve the problem of stigma, when medical sociologists, among others, have done studies to see if that's the case and have found that that's not the case. And in fact, sometimes the biological model reinforces stigma by making people think that they have this incurable trait that they're going to pass along in their lineage, among other things. And the other thing that we overlook in clinical research is the very systemic way that stigma and racial oppression, in addiction in particular, have reinforced each other. So in fact, in my sociologist colleagues in studying low-income white people in the Appalachians who've been deeply affected by the opioid crisis are finding that many of the ways that wealthy people in the area are talking about the low-income people who are dying of overdose, it's very racialized. It's very similar in the way that in states that are much more diverse than the Appalachian states, Black and brown people with substance use disorder are spoken about. So it just highlights the political nature of stigma and the way that addiction and racial stereotypes feed each other and lead to very punitive drug policies and responses to addiction. So I just highlight these examples to say that if we were to really take seriously something like stigma, again, we would need very different tools and we would need a different set of people around the table. To Dr. Glea's point that these kinds of systemic drivers of health inequalities are complex and difficult to address. I just want to, and also to his really apt point that we are a country that spends the most per capita on healthcare and gets the worst results of all industrialized countries. Okay, so we're doing something very wrong. And he's pointing out that other countries, for example, in Western Europe, do things differently. Among them, they take the social very seriously in their health research and in their health planning. In this country, we do have an example of how to work against stigma. AIDS activism gives us some really strong models. It involves elevating the perspective of people directly affected. It involves placing resources and decision-making power within communities in the way that Ryan White CARE Act funding does. And it involves rethinking research itself. So AIDS activists actually fought their way to the table to co-decision make around study design, around research funds for AIDS. And so those are the kinds of models that we would have to look to. And then to get to your point about PIs and researchers around the table, that would be the ethos that we would have to tap into to change the way that scientific funding is allocated, the way that promotion and recognition in health science is doled out. So I just want to put on the table that these things are difficult. It's difficult to take a systemic social approach, but we have lots of models for how it's possible, especially outside of the US, but in some cases within the US. And it's really, if we don't take those seriously, then it's a failure of our will to really do the things that would be needed to improve health outcomes and reduce inequalities.
I'll just add this point, and it's only because it's nagging at me. And that's around the conversations we have in rooms like this when we're trying to move small and big needles on outcomes that have seemed intractable. And the reason I'm lifting this up is because I think that the myth of complexity that we surround issues like behavioral health issues, racial injustice, all of those big thorny problems, like the way we talk about them also sets us up for failure. So I always, as a racial justice, healing justice practitioner, working in all parts of, many parts of Africa and watching communities there do so much more with less, I'm often reminded that it isn't that we don't have the tools. It isn't that it's so hard and, unsolvable. It's because of lack of political will. So I'm just going to say it. I mean, I think that, where there is a will, there is a legislative way. And where there is political will, privilege, even privilege that's unearned in structures and systems can be upended. So I'm saying this to say, I think, we've sent human beings to the moon. We have a worldwide communication system that allows us momentarily to be in touch with another human being on the other side of the earth. We have figured out how to, to get a vaccine into the population in record time. I think we can solve inequities. I don't think that it is impossible. Toni Morrison would always say that racism is man-made, and therefore it can be unmade by men and women who are willing to take the steps to move those needles. So I think that we can shift the inequities and we can change the composition of researchers that get funded. The question is, how do we sustain that agenda? And how do we make it so that it's not contingent on a few champions within an institute or an organization or an institution? Because what happens is if you don't structuralize it, then when those champions go away, we have all seen it. No one else is left around the study section review table to make the points that Helena's making or that Sandra's making or that Maggie's making. So I think that we really have to figure out how do we structuralize the principles that would be necessary to inform our decision making going forward? And how do we change the narrative around this so that we're not talking about things that are so hard or too big to solve, but that we're saying this is solvable with time, energy, and sustained commitment? I think that's what younger scholars are wanting to hear. We all mentor them, and they are leaving our institutions. They're leaving the field of behavioral health research because they're not feeling the love and they're not feeling that the immediate action to follow the work they're doing. So it's not just even about like moving the research agenda. It's like, how do we create the workforce within this ecosystem of behavioral health equity research that actually mirrors the passion, the commitment, and the stick-to-itness that we're talking about? And you don't do that if you keep reproducing the same science and using the same methodological approaches, because soon enough, those would-be revolutionaries and activists are going to leave the table and they're going to go to other places where they feel their work is being better utilized and their assets are being better deployed to help the people they so truly love and serve.
Very well said. Thank you so much, Dr. Powell. Dr. Alegria has had to step aside for a prior commitment, and we have about 4 minutes left. I want to give Drs. Galea and Hansen a chance for a final remark. Forgive me, Dr. Powell, I feel like that was such a wonderful statement. It pretty much qualified as a final remark. So Dr. Galea, would you go ahead and give us a final statement? And please focus on, I loved how you talked about small steps that we can take, right? And this is kind of dovetailing off of Dr. Powell's comments about how this isn't too complex. We can get this done. So what are your final remarks that you'd like to leave us with, Dr. Galea, about what should our next steps be? Where should we be emphasizing our focus right now?
Apologies, I was speaking on mute. So let me, I just want to echo actually Professors Powell and Hansen on a couple of things. First of all, Professor Hansen cited a data point that I feel like I've been citing every talk all the time for many years, which is we spend more on health than any other country in the world and we get less out of it. And the challenge I often pose to audiences is name one other sector where it's the case. And the fact is there's no other sector. I often use the example, if I were to tell you that your phone would cost more, but be slower and hold less data than any other country, you probably wouldn't accept it. You go to another country, but we accept it about our health. So the reason I think it's an important point is because to me, it's self-evident that we can do better. That's point A. Point B, I thought Professor Powell made this excellent point about, we are at a moment of potential and hope, but are reliant on good people in good places with good intentions, which I feel fortunate to be know a lot of those people, many of whom are actually on this call. And that's great, but it's important to actually move to a place where we embed things so the structures are not dependent on the individual. That's the second point. The third point is, I made this point earlier about the sort of radical vision and then small steps. And I don't want to be misunderstood about small steps. And I think Professor Powell echoed what I said really, really well about that, because I think wisdom, you got what I was saying. I don't mean small steps to be unambitious. I'm simply just being realistic that to get to a radical vision, it's a sum of many, many things. It's a sum of many things. And I often find sort of in panels like this, somebody says, well, what's the one thing you would do? And my answer is, I don't know what the one thing is, because it's not one thing. There are like 24 things that I actually think need to be done. So if you were to say to me, what should we do next? I think what we should do next is, if we accept that this is a vision that's worth aspiring to, then we should do the hard work of brainstorming about what are those little steps that we need to put in place and figure out what's required. So we can actually put those steps in place and then see how that is going to bring about change in the next year, next 2 years, the next 3 years. And I'm sure, if we structure this differently, if Professors Hansen and Powell and Alegria and I just brainstormed, we could easily come up with 20 steps that are each of them in and of themselves insufficient, but all of them necessary towards getting to the final goal. So I actually do think the next step is, what are those steps that need to be made, that would need to be baked into the system such that it actually gets us to our desired end, which is where we started from, which is where we are all doing work in the service of creating a healthier, better world so that everybody can live to their potential. Fantastic.
We're right at 3:10. Dr. Hanson, last words?
Okay, so looking at the chat, by the way, some fantastic responses and questions in the chat. One that I just wanted to quickly hone in on is that some have raised the question about what about Latinx or other people of color? I think echoing or anticipating some of what Dr. Powell said about intersectionality. I want to go back to what do the racial tropes that we're really talking about right now, the really embedded racial tropes and patterns that come from that, what are they actually? We know that they're not biological. They're actually a framework and a language that we use to describe power inequalities. And those are frameworks that operate across races and across groups. So many of the same dynamics that we're talking about, I use the example of Black Americans. We're at a rare moment in time when many of us are speaking openly about anti-Black racism, because that's kind of like the standard, like that's the gold standard of that kind of power inequality and systemic oppression. Many other people fit into that framework, and many people have intersecting identities. So I want to take the focus off of identity politics and put it more on the systemic narrative that we're trying to foreground now. When you look at systems, then you're looking at inequalities as relationships and power relationships. And so these are patterns that fit whether you're talking about anti-Black racism, which is a model that's then imported to anti-immigrant discrimination, anti-Muslim discrimination, gender discrimination. These things overlap and reinforce each other. And so I just want to point out that that's why we need a systemic perspective, not an individual perspective that would stop with somebody's self-identity or otherwise. We really need to look at how power inequalities are reinforced. And we've already had a rich discussion about how NIH might partake in that now and might partake in changing it in the future.
Great. Well, thank you so much to all of our panelists. Really do appreciate your time today. I believe we're going on break right now and resuming at 3:20. Is that correct?
That's correct.
That's correct.
Great. Thank you again to everyone and to all of our participants for your attention today.
Thank you.
Audio is okay this time. I think it is. Got the thumbs up from everyone. So we're going to move into our discussion session 2, which is focused on study design for studying racial inequities. This panel will be moderated by my colleague, Dr. Kathy Etz, Program Officer and Director of the Native American Program in a Division of Epidemiology, Services, and Prevention Research. Kathy, take it away.
Hi, great, thanks so much. First, I want to say thanks to the committee and to Will and Carlos who worked to plan this meeting, and also acknowledge all of the great presentations and discussion that we've heard so far. I, for one, am just blown away by everything we've been hearing, and it's just super exciting. So we've got a couple panelists to follow up on Dr. Verholden's talk earlier today. We have Dr. Verholden herself, and then we also have Dr. Willie Prado, who is a Vice Provost for Faculty Affairs at the University of Miami, and Dr. Brian Heckman, who is the Director for the Center for the Study of Social Determinants of Health and Associate Professor, Psychiatry and Behavioral Sciences from Meharry Medical College. So delighted to welcome them to be here with us today. I think when we designed the discussion breakouts for this meeting, the first one was really on the priority topics of research, and the second was on the study designs, methodological issues, et cetera, for approaching this area. And I think what is emerging very rapidly for me is the understanding that these things are just absolutely completely inextricably linked, and that to talk about one, we need to talk about the other. So in some ways, I think our discussion now will just be an extension of what we've already been talking about. I have a series of questions. There are 6 different questions to pose to you all, but my guess is that as we're going through them, we're going to find that we've answered some already, or maybe some are seeming a little bit less relevant. So if there's a pet question that I don't specifically pose, please make sure you nudge me in that direction. Hopefully we'll get to them all, but we don't have that much time. So the question I'm going to start with is, what research designs and methods are most appropriate for addressing questions of racial inequities? And I think we've already heard a lot, community-based participatory research approaches. How do we design the study? What are the actual, a randomized clinical trial relative to other designs, et cetera. So I think we could spend all day just on this question alone. But I want to kick us off with that. But actually, before I do that, I also want to really thank Dr. Verholden for her absolutely amazing talk and say that I am embracing this hashtag mandate equity idea. I think that's a great way for us to frame what we're thinking about. So again, our first question is, what research designs and methods are most appropriate for addressing questions of racial inequities? And I don't know, Deb, if you want to speak first, maybe we'll start with you and then move on to the other panelists.
Sure. So there are 2 points I'd like to add here. The first is health data disparities. I was working really, I'm an epidemiologist by training, and I was looking at the opioid epidemic prior to COVID. I'm still doing some of that work, but I am the only epidemiologist PhD level in my county. And so I work, pretty much round the clock on COVID and COVID related things, and I have been for a while. So when I was doing that work, one of the things that we noticed is that the quality of the death record and the quality of the data for the death record for African Americans was just not as good as it was for whites. And I thought, wow, disparaged even in death. There's something that happens when you see the Black body on the slab that has you not do as good of a job on the death record. And we thought, well, some places use a coroner and some use a medical examiner. Maybe it's a geography issue, and maybe people are, African Americans are disproportionately in places where they just do a poor job. And we looked at all of that. And guess what? Even in death, African Americans are disparaged and the quality of the death record isn't as good. So this idea of health data disparities is a problem, because what we get on the front end limits what kind of work we can do and the questions that we can answer on the back end. So I think that's an important problem. And then the other thing is, we often kick the can down the road on data, the kind of data that we could and should be collecting. And I think of that from the level of systems and structures. And the other panel, I thought, did just an excellent job of really unpacking sort of social determinants of health and more nuances around how we should be thinking about these problems. But, for your typical, treatment researcher, how will they get that kind of data to then be able to put their own work in a context to understand how those things work? And so we have major problems around data and health data disparities. And the last thing that I'll point to, so I'm not giving answers, I'm more calling out problems. And again, I'll go back to mandate equity, because we could mandate this. The data infrastructure and the lack of training and resources to look at these types of variables is something that we actually could fix. And it's something that we could fix right now. The last thing I'll say that I think is a methodological problem is in how we train people. I'm 22 years postdoc, and when I was coming through graduate school, we treated race like a nuisance variable. It just got adjusted out. And we would say things like, after controlling for, and then all of the things that we now realize are the things we need to be focusing on, I was trained to control those things or adjust those things out so I could understand relationships independent of those things. Lo and behold, those things are big drivers, or the structural factors that come with having those qualities, like lack of insurance, or living in a rural community, or being African American, or being non-gender conforming. We have to start to treat those things as important in the way we look at data and try to understand problems. So I'll stop there, and that's sort of an opening, and I'll turn it over to my great colleagues.
I think that's such a great, both of those I think were great points, and it's something actually that I always think about, and some of my colleagues have written about the health data disparities, and how there really is scientific inequity, not only in substance abuse, but in mental health and other areas. I think regarding study designs, one of the things that I always think about as we're thinking about methods and research designs to study underrepresented populations is issues around measurement. And I think there's an underlying assumption that if, at least in the psychosocial world and the behavioral world, if there are particular measures that work for non-Hispanic whites, that they work for other underrepresented minority groups. And the truth is that they don't. And a simple translation of a measure that has been validated with another population is necessary, but it's certainly not sufficient. And so I do think that we have to think about measurement, and we have to think about looking at carefully examining issues around measurement and psychometric properties and validations, so that we can really are confident that we do have measures that are rigorous and that are strong for the populations that we're working with. I also think another issue is that, going back, and I think my colleague made a great point about how we're trained, and certainly one of those is, controlling for race, and these are the findings that we have after we control for race. I think another way that we're trained is that the randomized clinical trial is the gold standard, which of course we know it's an ideal study design, it's got internal validity, but I think oftentimes we're trained that it is the only option or one of the very few options, and that it's the option no matter what it is that we're studying. And so clearly that's not the case. If we want to make causal inferences and we want to make some inferences, say, on racism, we can't randomize to different levels of that exposure, right? I mean, one, it would be not feasible, and two, it wouldn't be ethical to do so. So I do want to make the point that the randomized clinical trial is not always the most appropriate. I also think that we have to start thinking about study designs as we move, more innovative study designs as we move across, say, the intervention research continuum. Again, once we know that certain intervention works, whether that's biomedical or behavioral, and we're past the phase of efficacy testing, and once we move on to effectiveness or implementation, I do think we have to be more innovative in looking at other types of study designs, including hybrid effectiveness implementation designs, looking at rollout designs. Because again, I think that we oftentimes, because of how we're trained in graduate school and beyond, we always get very siloed to the RCT being the only study design option.
She's on mute, so I'm going to jump in. I want to give that an amen. An amen. And dissemination and implementation science was very new for me because I got the sort of classic training. And so we just did a very large hybrid type 2 trial of the Strengthening Families program in my city, in the city of Flint. And we paired that with a community-wide program to integrate peer recovery coaches into the sort of system of care. It was one of the most transformative programs, and who knew that how we deliver behavioral health care would be radically changed because a pandemic was on the horizon. But I thought I've got to have some rigor to the work, but I also have to have an opportunity to implement programs that we know work and figure out how to best do that. Literally, it was the perfect timing, and we have held on in the face of the pandemic and all of the cracks in how our behavioral healthcare system worked and was able to respond during this crisis. So I just wanted to give that a amen. I 100% agree. And I think funding has to go with that, because when I think about all the leaks in the pipeline, it's heartbreaking, right? I remember the first R01 I submitted, it got scored, but it got a really terrible score, right? This was an old system where it went from like 1 to 90 or 100 to 900. And I didn't even understand how it was discussed with the score that it got. And I was like heartbroken. You pour your heart, your soul, all your training into something, and then your peers say, not good enough. And so I really am curious, what is the cultural shift that we have to make so that these hybrid type trials really stand a fighting chance in review? Because that area of dissemination implementation science is not new, but there's not a lot of experts, and specifically in the substance abuse and addiction space, So I just wonder how those grants will fare in review. They'll never even make it to council, potentially.
Yeah, I think that's an excellent point. And I think also related to randomized clinical trials, Willie, I'm really glad you brought that up, because I think that that's a big challenge in this area, right? And we also have the distrust of communities where they don't want to be randomized. We also have, and we make a lot of, we have a lot of faith in the randomized clinical trial, and yet in the community setting or any real world setting, it violates a lot of the assumptions, right? So there are questions of, does this even have external validity? Does it tell us what we think it tells us? So I think that could be an all-day conversation. I want to let Brian weigh in here too. So Brian.
Yeah, well, thank you for passing that off. I'll throw in a hallelujah to it's already mentioned earlier, but I'll kind of follow up on the RCT alternatives, and particularly if you're trying to maintain the trust that takes a while to actually build, thinking about your control group is also really important. So, you know, you can have alternatives like a stepped wedge design where everybody actually does get the intervention at some point, or some of these other adaptive designs like a sequential multiple assignment randomized trial, or SMART, for easier to say, or these micro randomized trials where you kind of are able to test multi-component interventions by turning some things on or off and finding out for whom it works and when. So really taking into a greater degree the context, both on a daily basis, but also at the environmental and systemic levels. So kind of core to all of that is kind of understanding, going back to the idea that, you know, instead of just controlling for something, we're actually looking at the intersectionality as well, and how some of these variables might influence one another. Or work in conjunction and maybe work differently in different populations. So thinking more about advanced statistical and approaches as well. So using like moderated mediation or mediated moderation, or many other kind of forms with which you can develop these conditional or process type of analysis. And also thinking about how we can use secondary data analyses on the massive amounts of data we already have on these topics, but just hasn't been explored, or it has been explored, you know, via traditional methods, but could be adapted using like AI or machine learning to identify, you know, what are the core facets that are driving a lot of these kind of outcomes, and then how can we kind of modify those within. And I guess at a broader level, also just thinking about not only just analyses and approaches, but data repositories that could be accessible, and in relation to that, kind of data harmonization and systematic ways to measure everything. So fortunately, there is the social determinants of health core items and additional special collections within the Phoenix toolkit. It's nice to see that certain funding announcements are specifying you need to be implementing these measures, but just think if kind of like the mandate equity, if in addition to a power analysis of every statistical plan, you had to have an SDOH plan. And now, you know, maybe those researchers not every researcher in the world necessarily has to do the analysis, but maybe that data would at least get dropped into a folder that is accessible to everyone else that does want to focus on that, which would allow us to look at a much wider array of outcomes and the intersectionality of different populations and different outcomes and health domains in general. So
yeah, that's great. Yeah. I love that we'll have an SDOH plan as well as a power analysis in every grant application. I love that. I hope that.
I apologize to my colleagues for adding extra writing then, if that.
Yeah. That's all right. So I want to move us on to question number 2, because I think it is related to this conversation that we're having. And that question is, how do we balance generalizability, scalability with cultural adaptation? And I think there's the precise question around cultural adaptation in that. But to me, it also begs questions really about the value that we put on generalizability when, again, we know that randomized clinical trials are violating so many assumptions. Do we really have the external validity that we think we have, such that the interventions we're testing are going to generalize exactly in the ways we think. So I think embedded in this, there's a little bit of that RCT question, but then also, this really critical question about cultural adaptation. Obviously, for working engaged with communities, we need to be responding. Willie, you brought up the measurement issue. So just posing this question on generalizability and cultural adaptation. And who wants to go? Willie.
I'm happy to start. I think it's such a great question, and I think that we have to focus on both. And I know that's sort of the easy way out here, but certainly there's evidence that culturally syntonic interventions are efficacious, and in fact there are some studies where they have been shown to be more so, and Felipe Castro and others have done some nice work in this area of cultural adaptations. I also don't want us to just focus on the cultural adaptation if it's going to impede the wide dissemination of evidence-based practices. And so I'm going to use terms that Greg Ahrens and Hendrix Brown and others have coined, and it's the importance of scaling out and also scaling up. So scaling out referring to the adaptation of an evidence-based intervention for another population and other settings potentially. And then scaling up, taking an evidence-based intervention and scaling it up to that particular population or setting. And so I think that we have to do both of those simultaneously. And I think the question becomes is, how much of an adaptation do we have to do before we can begin to scale up? And I think Brian made some great comments earlier about looking at innovative methods, including smart designs. And so I would say we could also think about looking at which are the core components or the core ingredients of certain interventions that are driving the effects. And so, for example, here you're going to see my own bias of doing family intervention work. And so family processes are certainly common and important factors across multiple populations. So if we can disentangle the core ingredients of evidence-based interventions, when we adapt, we don't have to reinvent the wheel and start from the very beginning. We can build off of the great work that's been done by others. And then I think we can use innovative designs, such as what Brian mentioned. I think we could use other approaches like MOSE, for example, to try to understand which are the components that are driving to the intervention effects. So for me, it's both about scaling up and scaling out.
Fantastic. Deb or Brian?
Well, he said it perfectly. The only one thing that I would add to that is, and it's funny, right? Being a reviewer, we talk a lot about scalability and generalizability and, oh, but this is such a niche population. Is this really? But like, I think that's maybe the wrong way to think about it, right? Because we have, and I'll just use this COVID example right now. As an African-American, people are asking, how does the COVID vaccine respond for people who have sickle cell disease or sickle cell trait, which is predominantly in African-American communities, very overrepresented in the African-American community, sickle cell trait and sickle cell disease. And so I think about how would a grant have fared looking at, some medication in a sickle cell population because it affects a group that's only 13% of the population. And then that, disease expression is in a very even smaller, group within that population. But it doesn't mean that it's not important. It doesn't mean that it's not worth looking at. And so I think what's the training and what's the sort of value system that we have around generalizability and scope or impact? Is it important to understand good science and good practice in small subpopulations? I think if it's a value, then it has to match the resources. And then the other it's a caution more than it is a solution, is that we have to be real clear of a one-size-fits-all model, because we know that context matters. And that's what we're talking about today, right? These very, sort of social, political, community level determinants of health. And so that's why, again, I go back to, I think D&I, dissemination, implementation, science, and research is so important, because to go to Willie's point, how to get things scaled up and scaled out, those things are happening in a context. And so I think creating communities of practice built on good research and good evidence will be important, because how I implemented the programs that I do in Flint looks very different from how I was able to do them in Baltimore, right? It just looks very different, but there are lessons learned from the science behind scaling up and scaling out that I could apply, but there were really important contextual variables that made the two places very different, which required some adaptation. And so I see it kind of as a both and, not an either or. Either you can scale up and out, or either it's generalizable or it's not, right? We just have to broaden the way that we think about it.
Great. Brian?
I like the win-win as well, Deb. So ways to kind of find the best in both. And I think it's really important to keep in context technology and the role that can play in helping make a lot of these things become possible, both with advanced statistics and with, for example, like a smartphone. You can actually start learning what matters and to whom, and you can actually customize. You could still have the core elements, as Willie was mentioning, but maybe you'd modify the way in which it's delivered, or even the color of the screen or something, so that it's kind of more appealing or more attractive. So you can then start kind of influencing things related to treatment engagement and adherence, but also other outcomes that would come as a result of that. So there you can kind of do these mixed method approaches through like agile development, where it's very iterative with different focus group type of and user testing, and then being able to then actually scale that up pretty large, pretty quickly. And then being able to evaluate, again, through some large scale type studies, what's working and for whom, and being able to actually turn things on and off so that you can then, start modifying it in the context that's most appropriate for the patient population. So a couple thoughts on that. And then also thinking about how multi-site trials and consortia can work together, essentially to kind of already use best practices. So maybe it would also be in partnership with organizations that are outside of NIDA or substance use specific work, but already have infrastructures in place of working with different community stakeholders. And so we can kind of leverage already existing resources that are already in place, things like that.
Great. Great, thank you.
Can I say something about that? It's a real life example, and I'm going to tell one on myself if I could. This notion around technology and how we adapt models. I will tell you, we worked very hard to get the Strengthening Families program as a reimbursable program, because a lot, we have Medicaid expansion in my city, so a lot of our population is Medicaid eligible. And as we start to think about sustainability of programs and how we scale them up and how we scale them out and how we have them be able to be sustained when the research dollars go away, the state will actually pay for the program. And now it is a Medicaid reimbursable program. We did that work. The version of the program that they wanted us to use was adapted by our colleagues in Iowa, right? Because they deal with rural communities. And so getting families together and the way that the sort of classic program work wasn't really possible in many parts of Iowa. But it's a lot cheaper because you're not having to deal with transportation. A big part of the program is the family meal, which for a lot of families, it's the only time that they actually sit down together. We have many families that have participated in this program, not here, but also in my programs in Baltimore and in DC, who for many families, this was like the first non-holiday where they had actually just sat down on a regular basis and had dinner together and checked in with each other. So I was just like, I just was on, up in arms when the state said, we'll pay for it, but we want you all to try this new model that also has strong evidence behind it. And I was so resistant. And I was so surprised to find out that we could actually implement that program well, that it did solve a lot of problems that families had. We got really creative and had meals delivered to families. And so people would be on Zoom and things like that, having their family meal together. A lot of moms talked about it was the first time they cleaned off the dining room table in years because it's normally full of mail and other things. And lo and behold, COVID hits. And we are a demonstration site in an urban center for how to do a remote distance virtual version of this very robust, very efficacious, very effective program. Like, and I myself didn't want to do it. So again, it's like, how do we sort of build a case for and really disseminate how you can adapt programs when I know that there's resistance, because I see myself as somebody who's very nimble and flexible and willing to sort of venture out on the skinny branches of different study designs. But I can imagine there's, you know, resistance to that. And is there really funding for that? Right? Is there funding for the research behind it? This was implementation. This was the state paying for it. So we just basically did what they said. And then I did the research around it. But I just think there's so many missed opportunities. And we've learned a lot, I think, during this pandemic, that some of the ways we've been doing things, there's some other ways, but we need better data and better research and better science underneath of them.
Yeah.
And Deb, and if I may, Kathy, sorry, just one minute. I can relate to exactly what you're saying. And now it's sort of my amen to you, because I think that your points are right on. And as we think about the internet or online platforms, as Brian was setting for the dissemination of these interventions, I also do think that we have to sort of, again, balance that. This goes back to the adaptation question, because there is an adaptation that goes from moving these to a face-to-face to an online platform. And we have to think still about how to make that relevant to the context, to the population, without sort of losing that central focus.
Right.
Yeah. Yep.
Yeah. Okay. Thanks for those comments on that. I think those were all really important points. In terms of our next question is really honing in on these contextual variables. So what contextual variables should be included to ensure that findings about racial differences or racial inequities can uncover underlying causes rather than being attributed to race itself? And I think, you know, this sort of, Deb, harkens back to the statement you made in your talk, which is that, you know, there's nothing special about race that explains the differences, that we really, if we have this equity perspective, it moves us into this other way of thinking about it, and really, you know, looking at how we remove the fence and realize that it's these structural factors. But just specifically to hear from all of you, you know, what contextual variables and what other steps should be taken to support informed data interpretation.
I guess I'll jump at it. I think I'll first do a shout out again to the Phoenix Toolkit. So it kind of has some examples of individual and also systemic or structural types of questionnaires that can be applied. So the list could be rather long when thinking about the things that are related to race or kind of more downstream, whether it's wealth or dialect or neighborhood or social status, norms, skin color, religion, and so on and so on. But one can kind of see all those that are in the actual available online, but also thinking about other factors that might be like medical mistrust or stigma, and also protective factors. So different measures of resiliency or other kind of components that might buffer some of the relationship that's driven through some of these other causes. I think it's really important to add into people's kind of conceptual models, because the more we identify kind of some of these buffers or protective factors, the more we can actually build things around improving those in addition to decreasing some of the risk factors. So I just want to mention that. And then the other thing to think about is the way we define a lot of these terms or context variables. So, you know, context can be as subjective or physical environments, or it can be a number of different things. And when we say words like community, I think that might mean different things to different people, but we kind of usually just mention it. But the way in which most administrative or kind of publicly available data sets measure this might be way different than a citizen might actually define their own communities within like a citizen science-based approach. So whether you're talking about census tracts or counties or zip codes, somebody else might think about it as, you know, a much different context or different boundaries that actually represent their actual daily life and where they actually interact and what they see. So keeping in mind some of those factors as well, I think are really important.
Yeah, that's helpful. I think I'd like to reframe this question a little bit, and then Willie, I'll call on you. But you know, I think it's partially what we talked about in the last discussion session, where we think about, you know, the individual level, this more sociological level, the perspectives from different science, where we're not interpreting results as an individual problem, but rather that there are these systemic factors that are, so I think that's where we're sort of thinking to go there. So Willie, I'll call on you to see if that helps flesh it out anymore.
Actually, Kathy, you took the words right out of my mouth, because that's practically what I was going to say. And so I do think that we have to focus on some of these upstream factors that, you know, we typically don't focus on, you know, including certainly, you know, structural discrimination, societal structure. Maggie mentioned some earlier on in her presentation in terms of employment and certainly, you know, policies and laws. And I also think that political climate is an important one. You know, certainly I think we live in very interesting times where in some ways there's, you know, direct correlations between, you know, political climate and public health and other things that are going on in the country with systemic racism. So I do think that it is important to focus on political climate and societal structure, which are typically upstream factors that we have not focused on in the past. And just a shout out to NIMHD, you know, they have a great they have a great research framework, the National Institute of Minority Health and Health Disparities, that really does, in addition to certainly focusing on the individual and the interpersonal, there's really a strong focus on the community and more of the upstream level factors.
Great, thanks for that. Deb, anything to add there? Or?
No, I'm busy answering questions in the Q&A queue, because I know we're not going to get to them all. So I typed some because people were asking about the Phoenix Toolkit, which I do think is awesome. And I really appreciate Dr. Heckman for pointing us to that, because one of the things that I think, and if I look at some of the other questions that have been raised in previous panels, people say, you know, well, what are the best measures? And, you know, which things could we be including? And so, you know, providing tools and standards for people, because many of us were not trained to think this way, let alone, you know, sort of have the expertise. We might have the will or a core value to sort of broaden how we view the world and how we view and contextualize our research. That's very different from then actually having the practical sort of tools and skills to be able to do that. So I'll give another nod to the Phoenix Toolkit, and I did put the links to that in the chat for people. Just to harken back to what I did in my talk, looking at the causes of the causes, you know, this notion of downstream versus upstream. You know, I always tell people, when you identify disparities, I don't expect people to, you know, nobody trained me in how to be a researcher activist. Nobody, you know, I remember being a kid and there's that Schoolhouse Rock video, how a bill becomes the law. You know, there's so much more to how a bill becomes a law, right? That was a great video, but it didn't tell me that, you know, because I actually thought in graduate school and after graduating that data drives policy. Like, that made good sense to me. And then I realized data does not drive policy. We had data on the harms of tobacco use for decades before we actually got policies that regulated tobacco and put warning labels on tobacco products and things like that. So I always tell people, it's not data that drives policy, it's politicians that drive policy. And if you're lucky, you'll be able to use your data and relationships to influence a politician to drive policy. There's a lot more that happens sort of along the way. So I just think that, you know, us sort of saying it matters, using the great tools that we have, baking equity in to FOAs, to, you know, opportunities for improving pipeline. And I don't mean just getting people in the pipeline, because a lot of people get in and then fall out, you know, is sort of a start in getting us into the world of it. But I do think we do have a lot of knowledge and science around some of these factors, and we should be using those. So if people are sort of asking themselves, where can I start? The Phoenix Toolkit is a good sort of place to start. And then, you know, depending on who I'm talking to, I tell my research assistants all the time, Google it or Google Scholar it. If you go into PubMed and you put in social determinants of health, a whole lot comes up. If you go into, some of these really scholarly and scientific places where our work is disseminated, there are a lot of people who are, you know, sort of in this space. And so if this is something that we say is a value, I believe if we mandate it, people will figure it out. You know, you might have to be a little bit of a student again. And I see tremendous possibility there. I've got colleagues that I work with here who are doing equity work from the bench. I didn't even, and they said, Deb, you know, hanging out with you, how could I not get steeped in the work of equity? And they've got some really amazing studies looking at equity from the bench. And they point back to those early rat park experiments when we figured out that people will not just administer, or rats won't just administer drugs to the point of death if they're in nice parks with other rats and good food and wheels to run on and all that. It's like the first, to me, real preclinical study of social determinants of health.
Right.
Right? If you were miserable and didn't have anything that you needed for a life that you valued and loved, I think I might rather be high too. And we learned that from rats in the rat park experiments. That's real stuff. So I just think we have an unending opportunity to bring this lens in the work of equity and social determinants. We've got great tools that are always being expanded upon. And I do encourage people to check those resources out.
Yeah, thanks for that. And I think when we think about the complexity of the variables, the upstream, the downstream, it's hard to know what mediators and moderators, do we focus on mechanisms that we can change? Do we need to understand what those structural level factors are that really it's going to be the job of policymakers and not interventionists per se to specifically change. So I think it quickly becomes highly complex. And it's sort of hard to break it down, but I think thinking about all of those factors, as you guys have said, it's going to be important to frame the questions in such a way that we get to the right answers and that we move beyond these sort of individual level interpretations. I'm going to move us to the next question, and I'm actually just going to say, so the next question is, what are the implications and sample sizes needed? I think this question really comes from the idea that in some cases, health disparity science impacts small populations. And we sort of talked about that when we talked about culturally adapting interventions, and the example W gave about the sickle cell. I mean, if the population is very small, but it's a critical health disparity, then maybe it doesn't matter how small it is, you need to figure out how to study it. I think that's where that comes from. I would like to move us on because we're going to run out of time soon. So I would like to move us on to what is required to support true community engagement, because I think there's going to be a lot of thought there. But before I do that, did anybody want to say something quick about the sample size, or was there any other thought you had on that?
I mean, maybe just reiterating Brian's point about data harmonization, I think is a really important one. And then two, I think that the inclusion of minorities in research studies in any number isn't sufficient, right? So because we want to check off inclusion of women and minorities on our applications, and including a small percentage of those populations in our grant isn't sufficient, right? So in order to really generalize, as we talked about in the first question, I mean, we really do need to have studies that do focus on individuals of color and other underrepresented groups.
Okay, great. Okay, so with that, I'm going to move us on to what is required to support true community engagement. What mechanisms best support this, and what programs might be developed to support community engagement goals that are required to attain scientific goals? So I think just breaking this down, there are two parts to this question, and that is, in process, what's really required. And then the other part of the question is what NIH mechanisms exist now or could be developed to better support community engaged science. So 2 parts to that one.
So I'll go briefly because we got the questions in advance. So I'll do something I normally don't do for the sake of time. I'll read my answer and then add 1 extra sentence. So I said, we need more than goodwill here. We need real incentives for community engaged research and ongoing empirical research to demonstrate impact on outcomes and sustainability. The only other thing I would add to that is I think we have really perverse incentives in the academy for performance. And it's the hardest thing when I talk to fresh PhDs, new researchers, they say, I want to do this. And disproportionately in my experience, investigators of color have this just in their soul desire to give back, to do the work, to roll up their sleeves, to work with the people that they serve in the communities that they come from. And the reality of it is it doesn't generate the same number of publications. Those publications are harder to get put into high impact journals. And I always tell people, I'm like, it's hard, it's a heavy lift for a postdoc or an assistant professor. I worked on transformative legislation in Baltimore that was the single most thing that has happened in that city's history to reduce violence. And it was legislation to reduce alcohol outlet density. And I had all the credentials to do it. It took me 7 years working with about 120 other people on this legislation. We hadn't had a zoning rewrite in over 40 years in Baltimore. I got 3 publications out of that work. 7 years, my kids dragging them to hearings and community forums. They're eating at these meetings. So much time and energy, but it was in my soul to do that work. And I got 3 publications out of it. So just there's some disconnects and a context and culture in which performance and progress is rewarded that are inconsistent with community engaged work and community participatory research. And I work with Dr. Monahana Atisha, which I call her the Beyonce of public health. She is the whistleblower for the Flint water crisis. She had AJPH's article of the year. There were 3 publications that came out of all of that work that she did over the course of 5 years to get them to switch that water source back and stop poisoning the city. And all reviewers see when they get her application is, they look at the count. Well, 3 publications. How do you quantify the impact of working that way besides the number of publications that they have? So that's the other side of it, that on the other side, it's not a match. The incentives for performance in the academy don't match the realities of doing community engaged research, and we got to fix that.
So Deb, you and others can see me from here below, but literally I am off of my chair because it's the one point that I really wanted to make with this particular question, because clearly, the importance of community engagement and for all of us who do community-based participatory research, it takes a long time. And it takes a long time to really build trust with our community partners, to build genuine and sustainable relationships outside of, all right, I need to partner up with you for this particular grant. And then once we're done, well, I'm going to go find my next community partner. So I do think that point and your point about the academy is right on, because it takes so long, and because the tenure and promotion clock for most faculty is 7 years across the country. And you're putting your file together at the end of the 5th year, beginning of 6th year. There is an expectation that you have to have a certain number of publications. There's an expectation, particularly in medical schools and at schools of public health, that you have to have R01 funding or R01 equivalent. And the truth is that these types of formative grants where you are building the partnerships, where you are doing the community engaged work, isn't going to happen in an R01. In an R1, we're likely thinking about efficacy or effectiveness studies. So I think it's such a great point. And my point here was really to think about how the NIH and the academy can really sort of work together, because I think that there really is an opportunity to have both key stakeholders at the table as to how are we going to change this, because quite frankly, it's really, and I've seen this, it's really deterring some early career underrepresented faculty to work in certain communities because they're just not going to have the number of publications or the funding record in 5 years to be able to go up for tenure and promotion. And so I think that partnership really has to happen between the academy and the NIH.
Yeah, thanks for that. So we've got about 2 minutes left. We've got one last question on a review and how we can help the review system so that it responds favorably to these applications. We're not gonna have a lot of time, so I'll give you all, like, I don't know, just concise sentence on, and also I want to say for anybody who is listening to this meeting, if you have thoughts and ideas, please send emails to us. Also this panel, please share your other ideas with us because we are obviously eager to make some changes here. So how do we change review?
How much time do we have? No, I'm just kidding.
Yeah.
Yeah, right.
So I mean, I think a couple of suggestions, and I'll be very brief so my colleagues can speak. I think it's important to have representation, and I'm talking about more than just the one individual, the one African American or the one Hispanic or the one Native American, in a group of 30, 35 study section members. So I think it's important to do that. I think it's important for NIH and NIDA to continue to invest in funding mentoring programs for underrepresented groups. I think it's important to look at the data that are coming out on a continuous basis, not just the article that was done now almost, I guess, 7-8 years ago, in terms of the success rates by race and ethnicity of different investigators. And I also think it's important to not just sort of check the box of whether we're including, again, underrepresented minorities and women, but sort of the adequacy of that, right? So not just yes or no, are we including some underrepresented minorities in the study, but what's the adequacy of that? So I do think that, and kudos to NIDA and to NIH, there's been a lot of work that has been done, but I think there's still some more to do.
Okay, and I misspoke. We actually do have, I thought we were ending at 4:10, but it's 4:20.
Hey.
In addition, I know, what a bonus. So in addition to thinking about, how we can assess best practices for evaluating research equity opportunities and gaps in review, I also want you guys to think about your sort of final list of, I think the way that Sandra Galea put it was, with this clarity of radical vision, ID all the steps that are needed. And I know it's not just one step or two, but thinking about what are some of your important next steps. So first I'll let Deb and Brian weigh in on the review question, and then I'll ask you all for sort of your final thoughts on what you think some of the most important next steps are. And I'll tell you one, I think, is that we all need 3 days together to figure out the next steps. But.
Yeah, and listen, and I'm all down for that. So I'm gonna modify a statement that I made earlier, because I do think that data could drive policy in this context. We are scientists. We should be being informed by data. The NIH, NIDA, and I trust my great colleagues at NIDA, and I'm gonna call Kathy out. My very first R01 that I was a co-PI on, Kathy was my program officer. Like, I know you guys, I trust you guys. I know that there's actually will and real core values around equity, around pipeline, around like really solving a lot of our problems. Like, I know that because I know you guys, I know who you are. Dr. Volkow has been just an amazing director at NIDA and has pushed things that directors before her who helped to push science and other things. And she's had some good movements in science, but she is very much at the forefront of this work around equity in our space and in our field. So my thing is, what do the data tell us? What do the data tell us about where people are slipping through the cracks? I get the calls, I hear the stories from people. I can't even get a score for my grant, you know, and I redirect people sometimes, and I thought, okay, well, while, you know, addiction may be your outcome, your real framing and the real thing you're looking at, or substance use, et cetera, has more of a disparities focus or more of a this. So we need to actually be looking, what do the data tell us? And I actually do think it is incumbent upon us, especially these federal agencies, to let the data be the guide. And people like myself will say, okay, I will help you look at the data. We can all stand downstream with the numbers and the disparities. But that is my work, is to take a look upstream at what are the contextual factors. Dr. Galeo said it perfectly when he talked about being on review panel. This has happened to me so many times, and it's well-meaning, smart people who do it. They say, oh, I know her, she'll deal with that, she'll fix that, she'll get it straight. But imagine the really sharp, brilliant early stage investigator at a non-research one institution, at a historically Black college university that doesn't have a massive program of research, who is unknown to everybody on the review committee. That's how privilege works. Privilege gives people advantage, even when and if they don't want it. And it also puts others at a disadvantage. So we can't really answer the question if we don't look at the data and actually sort of do the work. And Kathy, I agree, and I would welcome the opportunity to roll up my sleeves and spend 3 days looking at the data, helping make sense, and helping to actually figure out what would long-term solutions look like. Not programs, not quick fixes, you know, and what's the ongoing work. I feel like the power for this is not just in the solutions, but a commitment and the will to ongoingly staying in the inquiry. Are we being fair? Are we being equitable? Are we losing people in the pipeline? Are we suppressing the potential brilliance and contributions of people because of where they are, who they are, what category they fall into? And I think we have a lot of goodwill, but we need good science and good data too.
Brian?
Well, you'll get another amen on that, Deb. I guess specific to the review aspect, I've always thought it could be interesting to think about diversity broader than just the actual people on the committees, but actually like their training or perspectives as well. So if you had actual like health disparity or social determinant of health type of curriculum certifications that people could actually go through some competency level training, and then actually be able to show that there's some level of education that has occurred or training. So we're currently working on some programs to do that. Or not only, we weren't thinking of just reviewers, but of like community health workers or other community partners, so that we make sure that when we're talking about certain terms, everybody's kind of on the same page. So, and I'll throw one, going back to the question about what's important for community engagement. I think communication is huge. And that's something that I think oftentimes scientists get caught up in our jargon or how we talk to one another, and not necessarily how we can most broadly and with the most appealing manner get the words out to people. So, you know, I think ways in which we can think about other public-private partnerships, and also just kind of across different disciplines, I think are the way forward in terms of really addressing these social determinants of health. And if we bring together the main key stakeholders and people with influence and power and money, that's where you're really going to start seeing these changes, and making sure that these conversations, which I was amazed that, I guess, what, 1,200 or 1,300 people signed up today. So there's great interest, and I've been a panelist on a number of these conversations for other organizations, but just making sure that there actually are real actionable next steps that can be almost in a centralized fashion, something ways other people can help contribute to, whether it's you know, helping identify resources, or helping you know, troubleshoot or planning, and then thinking about infrastructure building. So I've been at our major R1 institutes for over 15, 20 years. And now I'm at an HBCU over the past year, and there definitely were differences in some of the infrastructure that I kind of saw and availability. So making sure there are kind of partnerships tied up so that we can help identify and build more research infrastructure, and again, kind of leverage partnerships of ongoing infrastructures as well. So I'll leave it at that.
Great. That's an important point. Willie, I think the last word might be going to you.
I think my colleagues have said a lot of what I was going to say. I think, I just want to talk about that radical idea, and Sandra was so eloquent in what he said earlier. And I mean, I think just engaging with the academy and with the leaders of the academy. So we share common goals, the academy and NIH. We both want to produce knowledge. We both want to translate knowledge. We want to create the pipeline of the next generation of scientists. And so I do think that working together and creating that bridge and coming up with solutions together, I think is going to move this particular agenda forward. So, and I'd love to thank the committee for the invitation, and a shout out to Aria. Deb, since you gave a shout out to Kathy, I'll give a shout out to Aria, who was my first program officer, my first R1.
Okay. Okay. Any last thoughts anyone wants to share? Are we good?
Now, I'm just grateful that you guys are up for the conversation. So I thank you for having me as well.
Sorry, Brian, go ahead.
I was just saying thanks all as well.
Yeah, well, I think that we are all incredibly grateful to all of you for the fantastic work you do out there, and the ways that you're able to put all of this together to help us move forward. So I just want to thank both the panelists in this discussion and the previous discussion. And then Will, I don't know if am I turning it back to Carlos?
Yes. So we've decided to, thanks Kathy, and thanks to all the panelists. I think, really interesting. We've changed a little bit the schedule because we realized there was going to be a break and then just final remarks. And I think our final remarks are going to be very brief. So we're just going to skip the break, and that way everybody gets a little bit of time back. We will have formal summary of or recap of today's presentations tomorrow at the beginning of tomorrow's workshop. No, but to me, for me, today has been fantastic. No, a lot of topics have emerged. I am maybe a little bit more confused than I was at the beginning of the workshop, but I think that was the goal, to get a lot of ideas, a lot of discussion. I think we have had two very good keynote speakers and excellent panels. And some of at least for me, some of the lessons are the importance of acting at the system level. So even though we care about the individual, many of these problems are systemic, and we need to address them with systemic solutions. And so some of them would be what Helena was mentioning about alternative narratives, what Maggie was suggesting about addressing policies, and what Deborah was saying about engaging science to influence practice. So I want to thank everybody for your discussions, and also those of you who were not able to directly participate, for your participation through the chat and your attention. And with that, I want to turn it to Will for the last few words, and then I guess set us up for tomorrow.
Great, thank you. And I certainly want to echo Carlos' sentiment in that this was a very enlightening meeting, something that I think we really did not take lightly in terms of challenging our meeting organizers, our contributors, to really think boldly. And that's something that came from the top, from Dr. Volkoff, is to really think boldly and not to be confined to some of the challenges that we faced in the past, or areas of research that we were generally accustomed to, but to focus and think big. So I think the discussions really centered and provided some very concrete points of moving forward in that direction. I just want to highlight some of the overarching themes that I thought were very actionable, that were items that we can really move forward on. And I want to challenge our session tomorrow that will focus on basic science and the impact of racism and how social determinants of health should factor into those studies as well. And so I think Dr. Deb Verholden provided intriguing insights on really defining health equity and the social determinants of health, really disentangling that and making sure that it's clear that there are ways to really distinguish those and important questions thereof. Also distinguishing health disparities and health inequities as opposed to health equities here. I also thought providing a framework for kind of the upstream versus the downstream factors of health, which are vitally important in terms of moving these ideas forward in a very concrete way, to very much look at ways to objectively, not only objectively measure, but objectively evaluate over time. And that's what's needed. Looking at these changes over time, equity. And that is something that really spoke volumes. And I think is really undergirding today as well as tomorrow, is to really think through the mandate of equity, not just something that is just a snapshot in time, but again, a mandate. And when you speak in those terms, I think it forces us to really challenge ourselves and think about how can we not just click a box or check a box in thinking that we've done something meaningful, but really mandate. And I think when we think about it in those terms, change is likely to happen and likely measurable. Some of the other points with regard to treatment that really stood out, and I think will be important to think about long-term, is that only 30% of people with substance use disorders are receiving treatment. So that leaves a lot of people who are not receiving care, but there's some missed opportunities there. And so I think this discussion or our discussions tomorrow will be important to help with the focus on reintegration and recovery, as some points that Dr. Alegria noted. And again, I just want to get back to the important aspects of the mandate. And that is an overarching theme that I think will likely drive us through this effort going forward. And I thank Dr. Verholden for that call to action, because it most certainly is. Also, the data sources that allow elaborate simulations. I mean, we talked about other strategies to design studies that may not rely solely on RCTs, but other integrative designs that could really help to shape and move and understand behavior change in that way. And I just wanted to note a couple other important aspects that really stood out, and just involving perhaps non-NIH reviewers into the structure. So I think the structural components of this challenge is one that is deeply rooted. And that's something that I think is an important theme that came up today. The HBCUs really serve as a model and has provided a blueprint. And I think Dr. Helena mentioned this very articulately, is really moving excellence through responsibility to the community. So the responsibility that we have as scientists and researchers and clinicians is to the community. And if that is our guiding principles going forward, then I think equity and really that mandate is something that will be important as we move this, as we move these processes forward. Compassion over empathy is another driving principle that I think will be important to really move this forward. The lag time between research finding and how that information is disseminated to communities of interest, I think is important. And also along the lines of really thinking big is these moonshot approaches. So not really thinking small, but moonshot. If we can have a vaccine developed inside of 1 year, if we can do other things that really call for us to come together, the experts, the thought leaders, to really drive this home, we can do this. We can focus, we can work on health equity in a major way, not just in an incremental way, but in a significant way to move the needle. And I just want to close on two other points, is that the issue, yes, it's been long-standing, it's been deeply rooted, but I think the groundswell of support that we've noticed, over the last year has really been heartening. And I think it really speaks to the value that I think coming together as scientists, as researchers and providers to really think boldly and to move this forward. And I think it was well said that it's not too complex. They're deeply rooted, but not too complex. And I think with time and commitment, that is something that we can move this forward in a way that can offer the systematic solutions that we all need. And the final point is on impact. And I think there needs to be, and that was said, a premium on impact versus publications, right? I think there's a notion that with publications, there's only a select, I would say, outside of the research community that really review the publications, but the impact, I think, goes a long way. Dr. Verholden mentioned that the work that she's done that impacted legislature and policy, that it takes some time, it takes years. So I would value, and I would challenge my colleagues to value the impact of public health and policy, and how those really drive those changes are vitally important. And I would weigh that heavier over a publication. So I think that's something to think about, and including social determinants of health as a plan, as we do with having a plan of ensuring sex and gender differences and analyses. I think having a social determinants of health plan, as was brought up by a panelist, I think is important as well. So with that said, I want to end on that note. I just want to thank everyone, the panelists. I want to thank the keynote presenters, my colleagues, the moderators, as well as the contractors. Tomorrow is going to be, I would say, equally valuable. We're going to talk a little bit, we're going to change directions and focus on harnessing basic science to understand racial disparities and the impact of racism. And I think the challenge would be to have the panelists, the keynote presenters, think about how these social determinants of health can be integrated in that basic science sense. I think there was a lot of interest. Deborah Holden, some colleagues responded in the chat about the study that you talked about, the basic study that you talked about. So I'm sure there will be some interest in that tomorrow. So we want to end there, and I think Carlos, that would be a good wrap up on day one. Any questions before we part ways for today? All right, well, thank you everyone, and look forward to seeing you all tomorrow. Thank you all for a very successful and intriguing day one.